Everyone had gone to bed. I sat alone in my workshop, watching the
Atya. இது வரல வீடியோ போட்டோ வர்றேன் இது
Sir, good evening, sir.
Good evening.
குட் ஈவினிங் செந்தில்
Sir, yes, sir. Anand sir line lo vararu, sir.
குட் ஈவினிங் ஆனந்த்
Good evening, sir. President, sir, welcome, sir.
தேங்க்யூ
Hello, good afternoon, sir.
ராஜேஷ் பாபு குட் ஆஃப்டர்நூன்
Welcome, President, sir. Sangudivan, sir.
குட் ஆஃப்டர்நூன் ராஜேஷ் தேங்க்யூ
Good afternoon, President, sir.
குட் ஈவினிங் ஆர்எம்கே சார்
Good afternoon, sir. President, sir.
Sir, welcome, sir. Name sir.
Good evening, welcome. Good evening, sir. எப்படி இருக்கீங்க?
நல்லா இருக்கேங்க sir. Sir,
Senator
President
sir,
is
good
here,
evening,
sir.
sir. Suresh
Yes, sir.
Babu, Rajesh Babu, sir, good evening.
Sir, President sir is here. Yes, sir.
Good evening, sir. Surya Kumar, good evening. Good evening, sir.
Sir, President sir, shall we start, sir?
We'll start.
Another 2 minutes.
Senthil.
Yes, sir. Okay, sir. Anand sir.
Yes. Shall we start, President sir, or we'll wait for Karthik Prabhu and Sridhar sir to join, sir, or shall we start, sir?
Oh,
Yes, sir. We'll start, sir. When they're joining, they told will be joining now, sir. Then and there we'll call them, sir.
right.
Yes, sir. I think sound கொடுப்பீங்க. A very good afternoon, respected President, sir, and the chief guests of the IMA, Tamil Nadu TNSB, they'll be joining shortly. And I would like to, on behalf of the IMA CGP, I would like to welcome you all for this inauguration of this infectious disease course and the CME on rabies. So I would like our Director of Studies, Dr. D. Sandil Kumar, to give the physician prayer and that way also followed by the welcome address by the presidential address. Sandil?
Yes, sir.
Yeah.
Thank you, sir. I am a prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Christian prayer. Dear Lord, though great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray, give skills to my hands, clear vision to my mind, kindness and sympathy to my heart, give singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guilt and worldliness, that with the simple faith of a child I rely on thee. Thank you, sir.
Thank you, Dr. Sandil, for the IMA and physician prayer. Now, I also request Dr. Sandil Kumar to propose the welcome address for this gathering.
Thank you, sir. Today we are having our infectious disease fellowship course inauguration, followed by the infectious disease special CME on rabies, which is a most important topic right now. We are hearing lot of cases and even deaths here and there. So let us hear a good information from all the stalwarts. So I welcome our President, Dr. P. Sengatuvan sir, to inaugurate the course as well as the CME. Our past President, Dr. Abul Hassan sir, President-elect, Dr. Sridhar sir, our Honorary State Secretary, Karthik Prabhu sir, Finance Secretary, Dr. Gauri Shankar sir, and all our CGP wing office bearers, and our course coordinator, Dr. Neminathan sir, who has done a wonderful job in the past as well as going to do in the future, and all the star speakers of the day. I welcome you all for the CME and the course inauguration. And most important, the members who have registered in large numbers. We have close to 800 registrations as of now. I welcome you all. Over to you, sir.
Thank you, Dr. Sandil, for your kind words. Now, I request our Honorable President, Dr. P. Sengatuvan sir, to address the gathering and that will also inaugurate the course. Sir Sengatuvan sir.
Right. Thank you, Anand Chokalingam. Respected President-elect Dr. Sridhar, respected past President Dr. Abul Hassan, Honorary Secretary Dr. Karthik Prabhu, Finance Secretary Dr. Gauri Shankar, CGP Director Dr. Sandil Kumar, CGP Secretary Dr. Anand Chokalingam, Course Coordinator Neminathan, and past President Dr. RMK, and all the office bearers of the CGP group and Tamil Nadu chapter, I thank for the opportunity for inaugurating this infectious disease course. I hereby declare that the inauguration of the CGP course today with course coordinator Dr. Neminathan. The CGP group wing is doing a wonderful job creating all the awareness, and CME programs are doing very nicely. And it is one of the wing who is actively promoting the CME programs successfully and doing great job. The practitioners will be getting very adequate knowledge, and they will be benefited by these programs. With these few words, I also welcome all the course coordinators and speakers of the day. Thank you. Thank you. Over to Anand Chokalingam.
Yes, sir. Thank you, sir. Thank you for a very kind words of appreciation, sir. I would like to continue with the same, sir. Now, I would request our State Secretary, Honorable State Secretary, Dr. Karthik Prabhu, sir, to give his words of felicitation. Dr. Karthik Prabhu, sir.
Thank you, Anand, sir.
Yes.
Respected President and all the leaders. Good evening, everybody. Sir, I think CGP, needless to say, as President already told, you're doing a wonderful job. And this course is a very, very useful course, and nice to see so many, more than 300 participants registered for Rabies. So that is a very fantastic topic. Nice speakers, whoever you've chosen. All the best, sir. Best wishes, sir. Look forward for a very successful course. Thank you.
Thank you, Dr. Karthik Prabhu, sir. I think he's in the travel, speaking from the airport. Sorry to disturb you. Okay. And as far as the CGP is concerned, I would like to mention a few, since the registration is above 800 and many people have already known about this courses being conducted by the CGP, I would like to do a short preview of like what is happening in the state CGP wing of Tamil Nadu. Actually, the state CGP wing of Tamil Nadu, we are conducting 6 or 7 courses. And this year, this course, last year, this was a very successful course. Fellowship in infectious, more than 40 people joined this course and they successfully completed it. And the rest of the courses, we have a course which was inaugurated 3 months back on diabetology, and one course was inaugurated on sexual medicine. This is the 3rd course to be inaugurated now. Sorry, the 4th course to be inaugurated. 3rd course was respiratory diseases, and the 4th course is this now for this year. And shortly, in another 15 days to a month, we are going to inaugurate the newest course, which is one of our brainchilds of our President, Dr. Sengutuvan, sir. It is a neurological course. It's an office-based neurology for general practitioners. So we have an excellent team of faculty coordinated by Dr. Balamurugan from Salem, with all stalwarts in neurology and ENT people also there. So it will be a really good course. Then and there we'll be giving the Ntima we have published, and already people have started registering for the course. So if people who are watching the CME are interested in the neurology for general practitioners, you can well use that, and you can go into the Ntima and have the details regarding that. Or you can contact Juliet or Dr. Chella, Mr. Chella Gurai from IMS State Office for it. And as far as this CME is concerned, we need to have a very good topic for the current trend happening because of the stray dogs everywhere, pan-India problem in this. So today morning I was happy to have inquiries from Bombay, from Delhi, and from Andhra, Telangana. All these people have joined in large numbers. So that I hope this will be useful for all of them. And I would like to thank our faculty under the leadership of Dr. Neminathan, sir, who is taking great efforts in promoting the course, and the star faculties we have like Kalanisamy sir, Surya Kumar sir, Mohan Kumar sir, the coordinator. So all the topics are given today. Is also, and Suresh Kumar sir is also there, and D. Suresh sir is also there. So you're all stalwarts in your field. So I request the participants, if they are interested, you can join the course. We are starting it in June 1st. It will be the first official class of this course. So thank you for the kind words of listening. Now I would like to invite our immediate past President, Dr. Abul Hassan sir, to give his words of felicitations. Sir.
Thank you, Anand. Good afternoon, all of you. Respected President, all my office bearer colleagues. CGP is going courses after courses. Congratulations to you. I am very happy that you are starting infectious disease courses. Particularly today's topic is very, very relevant, and it is very, very important. You know, the treatment and also the categorization, everything has changed over the years with regards to dog bite. So I think the delegates who are joined will be immensely benefited by the excellent faculties. I think I should wholeheartedly thank our faculties, Dr. Palandisamy, Dr. Raghunandan, Dr. Neminathan, Surya Kumar, and Dr. Suresh. All have been very frequently doing this webinar on IMA's request. Thank you very much, sir. And I wish the event and the courses all success. Thank you very much for the opportunity. Over to you, Dr. Anand.
Thank you, sir. Thank you for your words of appreciation, sir. Now I request Dr. Sridhar, sir, our President-elect, to address the gathering, sir. Sridhar, sir. Sridhar, sir. Sridhar, sir was there. Sridhar, sir, are you online or?
Sir, sir is on the line, sir. Yes, sir. Just will wait.
Yeah.
You have unmuted me only now.
Sir, yes, sir.
Sorry, sir. Okay, sir.
Sorry, sir. Yes, sir.
Good afternoon, everybody. Respected State President, Senguttu Secretary, Treasurer Gauri Shankar, and the elite office bearers of IMA CGP, Dr. Sendil Kumar and Dr. Anand Chokalingam. And CGP has seen a upsurge or renaissance over the past few years, and we have been seeing wonderful topics being taken up for fellowship certification courses. And now this infectious diseases has come. If you look back by 2000 and 5, 6, 7, the non-communicable diseases, so-called the NCDs, took over from the infectious diseases. And they were given much more significance, like diabetic management, hypertension management, cardiac illnesses, and all these things. And then Corona came, and people awoke. They woke up from a slumber, thinking that the infectious diseases were things of the past. When the plague, malaria, filaria, typhoid, all these things used to rule the roost. They thought they all were over, but Corona shook them up and said, "Oh, we are here only." And now it is the year of the viruses. Viruses, they have taken over the whole world by the jitters. And one virus which has been defying logic, which has been defying a total cure, which has been defying relief for the medical profession and the patients at large is rabies. You will agree that we have been finding it very difficult to take a total control over that viral infection, maybe prophylactic, maybe prevention, but curative side has been very much questionable all these years. And I am sure this course will throw light with so many of the luminaries, the doyens of infectious diseases, Dr. Neminathan, Dr. Raghunandan, Dr. Suresh Kumar, Surya Kumar, and all these people are there. And I'm very sure they will be able to show us, throw a new light into the study of rabies and what it holds for the general practitioners, especially who live in the rural areas where dog bites, especially during the peak summer. These days are the peak days of dog bites. And I think this is a very apt time to start a course on this. And the CGP has come up well with a very good idea. I congratulate them, and I'm very sure and their numbers crossing 440, their interest is rekindled in the minds of our medical professional. And I'm sure this course is going to be a great success. Wishing you all the best. Thank you, Anand and Sendil. Over to you.
Thank you, sir, for your elaborate expansion and introduction to the CME, sir. It's a prelude to the ongoing process, sir. Now I'd like to hand over the mic to Dr. Neminathan, our coordinator, sir, so that he can conduct the proceedings, sir. Neminathan, sir?
Yeah.
Yes, sir. Thank you.
Good evening, respected seniors and IMA state office bearers, Dr. Senguttu sir, Dr. Karthik Prabhu, Dr. Sridhar sir, Dr. Abul Hassan sir, and Dr. Gauri Shankar, and my dear friends, Dr. Sendil and Anand, who are the pioneers and main role model for this CGP programs. And with your all your help, we were able to come to the 5th batch of infectious disease certificate course. And we are happy to announce that we have already certified more than 200 doctors in Tamil Nadu. One of the most wanted course that of the IMA CGP Tamil Nadu state chapter. And we hope there are at present more than 300 doctors who have shown interest. And at this rate, if many doctors join, I think this time we must make a century. We'll try our best to rope in nearly 100 doctors for the 5th batch. And I request my friend Dr. Mohan Kumar to give an short introduction about this course. Followed by that, our Director of Public Health, retired former Director of Public Health, Dr. Kulandeswamy sir, will give a brief introduction about the need for this infectious disease certificate course, and also he will give you just about the rabies in Tamil Nadu, and followed by Raghunandan sir and Surya Kumar sir will give an introduction about the virology, the diagnosis and pathogenesis about the disease, followed by myself and Dr. Suresh. Both of us will discuss about the vaccination and the frequently asked questions. So this is going to be thoroughly interesting and very much useful to the practitioners, because nowadays we see lots of cases of rabies. Not only rabies, the mortality is following, even in spite of vaccination is happening. We are going to tell what are the reasons for the mortality. And of course, you will all be very much interested in knowing lots of unanswered questions. Many of the questions in rabies are not answered in your standard textbooks. So CME is one place wherein you can answer whatever the question doubts the parents ask. So there are around hundreds of questions which you are going to answer one by one in a very, very elaborate and detailed manner. So this is going to be an evidence-based scientific seminar. It is going to be very, very interactive. As and when you have doubts, please put your doubts in your chat box. At the end, we'll be answering all the questions that is asked in the chat box. So with this introduction, I request all the doctors, nearly around 500 doctors have joined now. I request all of you to consider joining this infectious disease certificate course, because in our practice, particularly during monsoon time, 90% of our practice is infections. So if you master this skill of managing these infections, you'll be highly successful in your practice. So I request to take utmost priority and join this infectious disease certificate course that is going to be starting in June 1st. It is going to be online on alternate Sundays from 10 to 1. All the speakers for this Rabies CME are going to be one of the faculties for this infectious disease certificate course. And we are going to have various luminaries from the entire globe who are going to talk on the infectious disease. For example, for dengue, the class will be taken by the authority on dengue, Dr. Lucy Lum, who is the lead author of the dengue guidelines. Similarly, for each and every disease, we'll be having the topmost person in the globe to take classes. So that is going to be a boon for the registrants. With this brief introduction, once again, I'd like to thank Dr. Sendil and Dr. Anand for giving us this opportunity and always on the toes, motivating us. So it's your inspiration. We are following your footsteps. Thank you, Sendil and Anand. So I request Dr. Mohan Kumar to give a brief introduction about the course. Dr. Mohan Kumar.
Am I audible, sir? Sir, can you hear me?
Yeah, we are able to hear you. Can you share your
Yeah,
slides?
I'm going to share my slide. Yes, yes. Okay, so thank you everybody for this wonderful platform, and good evening all the participants who have joined this meeting. I'm going to take this 5 minutes to walk through the infectious disease course, which we were doing for the past 4 years. And the course just inaugurated by the the honored IMA leadership. So we call this as courses fellowship certificate course in infectious disease and infection control. And so what is this course? Basically, this course is focused for medical doctors. And this course is conducted through IMA College of General Practitioners. Like you saw all the leaders who are pioneering doing this wonderful job over decades. And it is implemented through this IMA Tamil Nadu state chapter. And the focus of this course is mainly on infectious diseases that are importance of India and international concern, mainly specifically focusing on the general practitioner's point of view. Like when you have infectious disease, you may have a lot of questions which is unanswered in textbooks, unanswered during our medical courses. So still prevailing among the colleagues. So we try to touch upon that. And also we also talk about epidemiology surveillance, how to manage an ID level, infectious disease at the field level. Okay. So this course is, we have already completed around 4 cohorts, and we trained more than 200 medical practitioners. The current course we are going to start in June 2025, and the classes starts on 1st June to 30th November, and the classes will be every alternate Sunday for 3 hours, and it's an online mode. I have a detailed detailed walkthrough of like how the courses operate. And of course, the registration is now open and it closes by 1st June 2025. We will post the registration point of contact in the chat after I present, so that you can contact if you need to join. So the basic objective of this course is like to update the knowledge and clinical success on infectious disease among the general practitioners, among the people, among the medical practitioners. And also we need to have create a platform on continued medical education, specifically on ID, because as Sir was saying, we thought NCD is going to take the world, but still ID is always there. And more towards like prevention, take care of our own community people who are getting infections, and also to have some research, like few of you or most of you must be having, okay, I wanted to do a paper publication, I want to do a small research in infectious disease, but we didn't have an opportunity. So this course helps you to do that. And we have initiated few research projects, and we have written a lot of theses among this. So who can join? So minimum education qualification is MBBS, of course, and he has to be medical councils. Not only Tamil Nadu, it is open for all in the national level. So we need, definitely there should be a member in IMA, and also membership in IMA College of General Practitioners is mandatory. If you are not a member, you can still join as a member and continue the registration. So that option is available. For example, you may be an IMA member, but not a CGP member. So you can still join as a CGP member with a small registration fee, and then you can join the course. So how the course is implemented? It is basically online, and the total duration of course is 6 months for a duration of like 40 hours. So every alternate Sunday, 10 a.m. to 1 p.m. Basically first and third alternate Sundays, and it goes like that. So you will have an alternate Sundays, and we mandate at 80% attendance. We also do 2 hands-on sessions. One is clinical hands-on along the bedside, or how to handle an infectious disease patient, and also we were proposing a lab sample hands-on, like always as medical practitioners, where we are sitting maybe in the hospital rural, we don't know how to pack, how precautions to be taken, how to do biomedical risk management. So all these things. Of course, we are very strict in examinations, and that is the quality rigor we maintain, and we have ensured that everybody goes through this. So we have assignments of 2 topics, which will be given the end of the course, fag end of the course, and we have written exam and Viva. Viva is conducted by 2 panelists, and you have to go to both the panelists and have a discussion, and they will understand how better learning you are doing. So with our experience, almost around 95% of the people have passed through all the three layers of examinations, and they got the certificates through IMA CGP during the convocation time. Okay, so what are the modules we basically teach? We basically teach syndromes. So what all the infectious disease syndromes we teach, we like the acute febrile illnesses syndrome, pneumonia syndrome, diarrhea syndrome, UTI syndrome, CNS infections, jaundice syndrome. So, and all the syndromes. And also we also cover specific diseases of interest like tuberculosis, HIV/AIDS, leptospirosis. We have topics on scrap typhus. We had very beautiful talks on malaria and dengue. We also touched in fungal infections, and during COVID, We had a detailed session on mucor also. And we also touched specific populations, like as and when we were going to the courses, people asked, okay, we wanted to know more about infections and elderly, infections and immunocompromised. So we tried including that. For example, this infections and NCD, specifically in diabetic infections. So these topics were covered in 3 hours, and it was very well taken by the attendees of the previous course. And the fourth point is like we were now talking about what antibiotic to use, how to do biomedical waste management, how to register ourselves in this Clinical Establishment Act, what it is actually talking, and how to manage hospital-acquired infections, how to handle sepsis, what are the alarm signs of sepsis. So we specifically focus on infection control because it is an infectious disease course. And also we had public health focuses. There are some emerging diseases coming. Suddenly we had monkeypox, we had Nipah, we had Ebola. As and when the diseases arise, we immediately try to cover the topic so that we are aware of what is going to come. And we have a detailed session on vaccination, both among pediatric vaccination and also adult vaccinations. We have 2 different sessions, which was well received by the attendees. And also, this is basically we try to do a case-based learning. It is not a like the board like PPT-based studies. It is always interactions. So after 2 slides, then the speaker will stop and they will ask questions. So you can come and also we have like error panel reviews. So we tried more interactive during the sessions. As Dr. Emilian sir was saying, we had around more than 40 national and international experts on specific areas. So if you wanted to talk about liver, okay, we go to the hepatic liver specialist. And if you wanted to talk about vaccination, then we reach out to the public health experts. So we try touching about state governments, central government departments, leading institutions, research agencies, international agencies, so that we give best teacher for us to learn. And so this is implemented by this FCID course committee, like where we were the core committees, and in collaboration with IMA CGP, IMA Tamil Nadu State Chapter, and Medical Council for credit hours. And we give 10 credit hours for the whole 6 months based on your attendance. So when you register to the course, you can avail the credit hours as and when we progress through the course. So just a snapshot of all the core committee members. And so we have varied distribution of the experts. We are just managers and we usually take sessions, but we identify experts for specific topics so that we talk less and we ask the experts to talk more. And I hope this is a quick shot. I will share the slides in the chat and also the registration link for the courses. And I thank you, and over to Dr. Neminathan, sir. Okay, now I invite Dr. Kulandasamy, sir, to talk about rabies, what we should know now. Sir, Dr. Kulandasamy, sir?
Yeah, please. Good evening to all of you. IMA Tamil Nadu Chapter Leadership, President, Secretary, and other office bearers, and IMA College of General Practitioners, and all the participants and all the experts and the course coordinators. Thank you for kindly inviting and organizing this course. I think Dr. Mohan has very clearly explained the need for this course. So if we look at the infectious diseases, still we have a lot of problem, particularly if we take this tuberculosis. Although we think that leprosy is out, still there are the certain pockets, and still we see in the dermatology department of medical college, still we are seeing cases. And similarly, a lot of, although we are eliminated or eradicating many diseases, for example, the smallpox had been eradicated. So in India, the guinea worm, in Tamil Nadu, the guinea worm disease had been eradicated. But still, we are facing certain, malaria is on the verge of elimination in Tamil Nadu. But still, the travel history becomes very important, because the people who are traveling to the African countries are people who are traveling to Northeast, particularly the Assam and the northern parts of Andhra Pradesh, Odisha. They are having, so in any case of infectious disease, it becomes important to ask the travel history. So this course highlights the need for the course and understanding. Many times we lose the patients. So for example, some 15-20 years back in Trichy, a lorry driver who went to who was taking load to the cargo to Kolkata. So on the way, this lorry got breakdown in Odisha, in the hill areas, forest areas of Odisha. So the overnight he stayed there. So he got infection with the Plasmodium falciparum. So unfortunately, the people who are treating, they fail to, because there is no cases of malaria in Trichy. If at all there are some cases, it may be Plasmodium vivax. So then the simple understanding, the simple thing to ask, so that costed the life of that particular driver. It's a very young man, about 35 years old. So they're asking, so why I am, and similarly the TB, there are many countries, they are doing various strategies. For example, they are screened with the tuberculin mantle test in the school children, among the school children, and they treat latent TB with a course of INH. If we don't treat the latent TB, then at a later point of time, it becomes a frank tuberculosis in one form or the other form. So these are all some of the examples, and also the vast international travel, the volume of the travel. So MERS-CoV-1, the situation, it didn't spread much because of the restricted travel. But that was not the case with the swine flu, and that was not the case with COVID-19. So any disease can spread across the world at any point of time. So given all these things, we need to prepare. And also during the dengue fever, the interaction, we conducted the Directorate of Public Health along with Raghunandan sir and other C. Rajan sir, Neminathan, and many experts. So we conducted the CME across the state, but still, since this is an internal meeting, I am sharing some of the prescriptions we find so very, very disturbing. So we even entrusted the medical college. So the three sources of the trouble comes for the patient in cases of dengue. So one it comes from the quacks, and another it comes from the medical shops over the counter. Then the third, it comes from the problem comes from the qualified medical practitioners. So then we have dedicated a medical the medical institution, particularly the professor of medicine and professor of pediatrician, so to collect such prescriptions and call them over phone and educate them that to how to handle these cases. So these are all some of the examples. So to highlight the importance, the need for this course, I think it's really appreciable that the IMA College of General Practitioners is I think almost they have, I think we have completed about 200 doctors, and many sessions on infectious diseases are organized, are well attended. For example, today also I think 500 plus doctors it is very, very encouraging that 500 plus doctors are attending this. And also the course name, if you look at, the infection control is also the infectious diseases, how to prevent and manage infectious diseases, and also infection control. So nowadays, the hospitals are becoming the source of infection. If you look at the swine flu, if you look at COVID-19, so the cases started in places where the most of the hospitals are concentrated. For example, Chennai, Vellore, Madurai, Tiruchi, Coimbatore, Salem. So then in and around Puducherry, Pondicherry, so these were the packets. So clearly illustrating that infection control in hospitals. The people who are affected by the spread of infection in hospital are mostly women, particularly pregnant women and children, and also the elderly people. So the infection control in hospitals also is very important. The basic the knowledge, the basic measures like hand washing, appropriate ventilation, so the appropriate sterilization, this kind of the infection control practices in hospitals also very, very important. So with this few words, since Dr. Mohan and Dr. Naimnathan and everyone who addressed earlier covered the need for this course. I'm going to the discussion on rabies. Just 3 points which are very important. The subsequent points will be, I think, the ID specialist Dr. Raghurandan and Dr. Suresh and other experts will be highlighting. So the number one, all the participants who are here should understand rabies, a dog bite or an animal bite, is an emergency, is a medical emergency, because the fact is the time taken by the wild virus to cause disease is around 10 days. The time taken by the vaccine virus to produce antibodies in the body in the human body is 7 days. So the gap between the onset of disease and the production of the antibodies is only 3 days. So that means if the dog bite occurs at 11 p.m. in the night or 2 a.m. in the morning, then even then it is an emergency. You should immediately rush to the hospital and get yourselves the ARV, if necessary. If it is a category 3 bite, then you have to get the immunoglobulin. This is a very important. We should all, particularly more so the emergency. The gap becomes narrower. If the bite is on the upper limbs, or the bite is on the neck or face, or the bite is on the closer to eyes, then it becomes further more serious that it is an emergency. We have to understand, we cannot postpone. Today is Sunday, today is Saturday, tomorrow, now it has become it's dark, tomorrow morning we will go. So these kind of things will not work. So we have to understand that it's an emergency. The number two, the treatment strategy. The treatment strategies, there are only 2 critical points are very important. The one critical point which is very important is the first aid. Immediate wound wash with the running water, with a high detergent soap, or if we have some the virucidal, the alcohol based, the virucidal this thing, betadine, or this alcohol based hand wash. So with this with a copious water, we have to wash. This is the first thing that has to be done, the first aid. And the second thing, the categorization of the bite. So we assume the WHO says the category 1, category 2, category 3. Practically, category 1 doesn't exist. There is no category 1. Kindly, if it is a lick, if it is an animal lick, or just the saliva is the saliva we have come across with the contact with the saliva, whatever it may be, kindly classify into category 2. There is no category 1. Please understand, the WHO has given a very wrong guidance, because the practical thing is different. That can you see? Can you show me a skin surface, the hands or in the legs or anywhere in the body, without invisible abrasions? Our body, when we are having in the active life, we are going to for work, we are walking, we are playing, we are working, we are doing manual work. You cannot come to a conclusion that my skin surface is without any abrasions. No. So for everybody, the skin surface will have minor or invisible abrasion. So when there is an abrasion, whether it is a visible abrasion or invisible abrasion, then it has the potential that it will, the virus has the potential entry into the human body. So somebody comes with a category 1 or category 2, kindly consider as category 2 and treat. This is another important point. Then category 3, of course, category 3 requires anti-rabies vaccine as well the immunoglobulin. It is very important. So now coming to the question, it was, I think, raised by one of the speaker, I think Dr. Neminathan. So why there are cases in vaccinated individuals? Why there are rabies deaths? Every year, we used to see earlier, in some 15 years back, we used to see about 50 to 60 cases yearly. Then due to intensive vaccination and initiative, not by dog control, please understand, not by dog control, it is the dog population is going on increasing, all the rules and regulations, everything is in favor of in favor of animals, not in favor of children or human beings. This is the this is a reality on the ground. So the reason why the rabies deaths occur. So sometimes the people in vaccinated people, the lack of first aid or the delay in getting immunized, or category 3 requiring immunoglobulin are wrongly categorized, or because of the non-availability or the cost factor, so many reasons not getting the immunoglobulin. This is one reason. And what is the reason why people ignore the vaccination? See, the one important reason to ignore vaccination is this puppy bite. This puppy bite, no bleeding injury. So they simply, and this is a vaccinated dog. So these are all the kind of reason, and some people go for native treatment. So these are all the reasons why they don't go for vaccination. And sometimes the patient, they may go for incomplete vaccination. These are all the reasons why people fail to get vaccination. And and partially immunized or in a vaccinated people, why why the cases are occurring, I have already explained. So the government initiative, so particularly during we made an initiative that to make the ARV available 24 hours basis in all primary health centers, and 24 hours ARV availability, and we shifted from intramuscular to intradermal. So intradermal, the 4 doses schedule, intramuscular is a 5 dose schedule. So the 4 dose schedule, so one vial we can definitely use it for 0.1 ml on either side of the, on both side of the deltoid. So then the 4 doses is enough. So even a patient comes at night, open a vial, reconstitute it and inject. There cannot be any delay. So no PSC should ask them to come tomorrow morning, or tomorrow is Sunday, you come on Monday. No such thing. And this immunoglobulin is also made available in upgraded PSCs on 24 hours basis. Upgraded PSCs, Medical College Hospital, all district headquarters hospital, and major taluk hospitals. So immunoglobulin also readily available in the government system. Private, of course, it is available in the private major pharmacies located in cities. But the cost is very high. So the patient cannot afford. So kindly coordinate with the government. I think all of us must be having friends. Please call them. So call the DHO, or call the municipal health officer, or call the dean or medical superintendent or the block medical officer, and make sure that the patient gets immunoglobulin. And also take note of the telephone number. Verify the mobile number. Call them whether your due is today. Have you got the second dose? Have you got the third dose? Have you got the fourth dose? So this should be followed up. The rabies patient, please take down the mobile number of the patient in your register and keep calling them and make sure that they complete the treatment. So these are all the basic things from our experience. And now we can go for the more scientific information session from the Professor of Medicine and NPCD's experts. Okay, thank you. Thank you very much.
So thank you, sir. Thank you for walking through the rabies, the need for the R. So many of us know, rabies. Okay, we will wait for 5 days. We'll watch the dog and all. But it is very clear now that any bite or any lick is not safe, and there is no contact skin. Always there is an unseen aberration in the skin. And also talk about immunoglobulin and try to connect with the government facilities is much more important, sir. Thank you for walking through it. Moving to the next speaker, we have Dr. Surya Kumar, who is going to talk about virology, rabies virology and lab diagnosis component. Dr. Surya Kumar, over to you. You have 15 minutes to discuss. And till he is loading up, I am going to post the Ministry of Health and Family Welfare guidelines in the chat box, because many of you are asking guidelines. You can check through it. Over to you, Dr. Surya Kumar.
Thank you. Sir, hope I am audible.
You are audible and slides are visible perfectly.
Okay,
sir.
Thank you. So I'm going to discuss about rabies virology. Basics, very basic, because you should know about your enemy. This is not a new virus like COVID-19 or SARS-CoV-2. From 1500 years before, 500 years before onwards, it is available. This virus, I don't want to go in depth of the history, but the basic, this virus belongs to a family called Rhabdoviridae, because we should know about your enemy. Number two, it belongs to a genus called Lyssa virus. Can you name one new Lyssa virus now? Everywhere it is flaring up in India. Chandipura virus. Chandipura virus also belongs to Lyssa virus. So it belongs to genus Lyssa virus, and the species is Rabies virus. So we shortly call them as Rabies virus. So it is genus Lyssa virus, species Rabies virus. Next is, this virus has various weapons. Before that, you should know about the nucleic acid of the virus. It is single-stranded RNA. What is the clinical correlation? Comparing with double-stranded RNA, single-stranded RNA, double-stranded DNA virus, single-stranded RNA viruses are more prone for mutation, more prone for resistance, and more virulent. And it is negative sense. Every virus, RNA viruses, we are classifying positive and negative sense. Negative sense means it cannot make its own proteins. It need host. That means the viral RNA itself act as a messenger RNA, then it is called positive sense. There won't be like that. It need RNA dependent RNA polymerase, that's all. So they possess an enzyme called RNA dependent RNA polymerase. Enveloped. What is the clinical thing? Any enveloped virus easily susceptible for liposolvents like ether, alcohol, acetone. Easily we can kill them. Non-enveloped viruses are more resistant to antiseptics. Enveloped virus, so be happy. Even the sunlight and the alcohol, ether, anything can destroy this virus. And it possesses helical symmetry. Majority of the viruses are icosahedral. Only few viruses like influenza, like viruses have helical symmetry. And you see the shape of the virus. Are you able to see the shape? What is the shape? It is bullet-shaped virus. Bullet-shaped virus. This is basics of this virus. And this virus has many proteins, matrix protein, RNA, glycoprotein, like many proteins, many weapons. We'll see one by one. Just function. G protein, very important. The next speaker, other speakers will talk about it. Its surface spikes bind to the nicotinic acetylcholine receptor at neuromuscular junction, helping in binding. And it is the ideal vaccine candidate. We got the vaccine. First time in the world, India introduced G protein based vaccine called Rabies. It is G protein vaccine. It is a vaccine candidate. Please remember, it's a virulent factor and helping in making an excellent vaccine. It is available in India, only in India. Next is nucleoprotein. It protects the RNA like a shell. It is helping in diagnosis because antigen for diagnostic test, direct fluorescent antibody test, we are using the antigen, we are using this. Large protein is RNA dependent RNA polymerase because it's a negative sense virus. It possesses RNA dependent RNA polymerase. So large protein. And phosphoprotein is helping in immune evasion, escape from immunity. And it inhibits interferon response because if interferons are good, automatically the viral suppression may occur. So it inhibits the interferon response, allow the virus to multiply. And finally, M protein, matrix protein, mainly for virion maturation, viral assembly and budding. So these are all the basic weapons of the virus. Basic weapons of the viruses. Next is, there are two types of viruses. One is called street virus. Another one is called fixed virus. What is it, sir? Freshly isolated from animal or human being, any patient or any animal, that is called street virus. If you maintain in the laboratory, that is called fixed virus. So what is the difference? Street virus is original, ferocious, all real characters are present. But fixed virus, because for survival, it adapts the laboratory environment, it lost many of its character. if I want to give the example, lion in the jungle is street virus, ferocious. Same lion in the circus, fully trained, fixed virus. This example, another one example also, everybody saw the movie. See this movie, this character. This is street virus, ferocious. This is soft character, fixed virus. So this is another, I'll make a small table of the differences. It found in naturally street virus, fixed virus created by passing in animals, laboratory maintained. High pathogenicity, it is highly attenuated. Sir told just now, vaccine virus can produce antibody very fast. So incubation period 3 to 12 weeks in this virus, here just 1 week. And characteristic feature, Negri bodies, everybody aware of that. That is present in street virus, that is absent in fixed virus. So fixed virus lost its important character called Negri body production. So these are all the difference between this one and that one. Next is reservoirs, everybody aware of that? All warm-blooded animals transmit rabies. Dogs is the most common offender. So everybody says dog bite, dog bite. And other animals, list of animals, cat, fox, jackals, monkeys, horses, a lot of animals are there, general points. And in India, common is dog, very frequent is dog. Occasional cats, monkeys, mongoose, foxes, camels, horses, donkeys, everything, occasional. But not reported from bats, rodents, and birds. Okay, not reported in India, bats, rodents, and birds. Even squirrels also not much reported, not reported. Because of the reason, if you see the guidelines, the vaccine speaker will tell which animal bite we need to give vaccine, which animal bite we should not give vaccine. And mode of transmission, all newspaper, all IEC material, all communication, everybody says dog bite, dog bite. That gives false message to the people. Anybody has a cat bite, they will not come to you. Because they say only dog bite causes rabies. Why should I come for cat bite? So please remember, everybody thinks dog bite, only dog? No, many other animals. Only bite? No. Sir told even licking, local inoculation. So mode of transmission, common mode of transmission, local inoculation by infected animal bite, licks on broken animals and scratches. Any infected material, local inoculation is one mode of transmission. Another one is inhalational rabies, exposure to bats in bat caves, not in our country, Latin America like countries. Hunters go to the forest. They want to stay in the forest in the what is called caves, bat caves, no sunlight. The saliva contains the virus. They inhale, they develop inhalational rabies. Ingestion of meat, undercooked meat, raw meat, they have the injury or ulcers in the mouth, possibilities. Corneal transplant, because the virus shed in cornea, corneal transplant, unscreened corneal transplant, but these are all very rare, corneal transplant, because nowadays we're doing screening. Nowadays we're doing screening, right? Next is, you know about the virus, how to identify as a microbiologist. I will tell laboratory diagnosis for another 5 minutes. Because it is 100% fatal disease. Even though if you diagnose, you cannot save the patient because it's 100% fatal. I asked my professor while he was teaching this, sir, why we should do diagnose rabies? Because 100% fatal, are you going to save the patient? Early diagnosis can save some disease. But here, he said, no, confidently you can write the death certificate. The death certificate, you can confidently mention the death is due to rabies. That's all, because we cannot save the patient. So laboratory diagnosis, as per government guideline, lot of tests are available. As per government guideline, I'm going to discuss about our Indian government guideline. If you go to the internet, WHO guideline, CDC guideline, lot of guidelines are available. But we need to follow our NCDC guidelines. There are direct and indirect tests. It's a menu. Available tests are direct and indirect. Direct test is detection of the virus antigen. Indirect test, detection of antibodies. So direct test, number one, antigen detection test. Cellular staining, demonstration of Negri bodies. What is DFAT? Direct fluorescent antibody testing. DRIT, direct direct rapid immunohistochemistry testing, RADT, rapid antigen detection test. These are all the tests available for antigen detection. Molecular method, always universal, RT-PCR. Nucleic acid amplification test, RT-PCR. Virus isolation, always go for culture. Okay, brain tissue or rapid tissue culture inoculation test. Don't need about all the tests actually. Virus isolation, culture available. Indirect tests are antibody-based test, ELISA, RFFIT, what is called rapid fluorescent flocculation inhibition test, and indirect fluorescent immunofluorescent assay test. Many are available. This is the menu, available menu. You cannot use all the tests for all the patients. We need to use how. The next 2 slides will discuss what are the tests you are going to use. There are 2 type of samples or tests available. One is ante-mortem diagnosis. Another one is post-mortem diagnosis. When the person is alive, that is called ante-mortem diagnosis. We can rabies RNA detection. That's the best. Another one is antibody detection. These 2 possible tests. What is the samples? Sample we are using saliva, knuckle skin, and CSF. Very easy to say. CSF is a sample. Is it easy to take CSF sample from a rabies patient? Do you think every patient is obey to you? If the patient bites to you, what you will do? The 2 type of rabies, furious and dump rabies. Okay, whatever it may be, these are the available samples. Okay, what test you should do? Okay, you do RNA detection, RT-PCR. RT-PCR test you do. If RT-PCR positive, you confirm laboratory diagnosis. Yes, rabies is present. Suppose if PCR negative, rabies cannot be ruled out. That's the problem, because sensitivity and specificity of the test. If RT-PCR negative, I cannot say he's not having rabies. But RT-PCR positive, I can say he's having rabies. Please understand. Next is antibody-based test. CSF and serum, 2 results will be there, positive, negative. In case of positive, you confirm, laboratory confirmed case. CSF and serum, in case of positive, antibody positive, yes, it's positive. Suppose antibody, in case of serum, if it is antibody positive, please remember, serum antibody positive, you consider the vaccine status, yes or no. If it's not at all vaccinated, but antibody positive, it is a confirmed case. Suppose if already vaccinated, you need to think the antibody due to vaccine or the virus. Okay, right. So CSF, if antibody test positive, positive. In case of serum, antibody test positive, ask the vaccine status. If vaccine status is negative, then he is positive. Then we consider this as positive. Suppose in case of negative sample, okay, again rabies cannot be ruled out. You repeat after 1 week. After 1 week, again the test is negative, rabies cannot be ruled out. Suppose after 1 week, if the test is positive, you consider this as positive. Got it? In case of serum, please remember, first CSF positive, CSF negative, 1 week later do the test. Again 1 week later it is positive, negative cannot be ruled out. Serum positive, ask vaccination status. If there is no vaccine, okay, you consider it as positive. If the person is vaccinated, repeat after 1 week. After 1 week again it is positive. After 1 week it is negative, cannot be ruled out. There is nothing called negative, cannot be ruled out. How you write at the end of the investigation? Okay, kindly correlate clinically to escape, like that. Last slide. Post-mortem diagnosis, patient death, ideal specimen, brain tissue, brain biopsy. Okay, if the brain biopsy available, 90% available, because we are giving post-mortem possible, available. You do direct fluorescent antibody test. If it is positive, yes, laboratory confirmed test. If it is negative, you can say negative. Here is the place you can say negative for rabies. Suppose brain biopsy not available. You can take skin biopsy, knuckle skin or CSF, do RT-PCR. If RT-PCR positive in single or multiple sample, it is confirmed either skin or CSF. If it is negative in all samples, it cannot be ruled out. It cannot be ruled out. The results can create problem in medical legal. If it is positive, you write confidently positive. If we say cannot be ruled out, he may not get the benefits or other thing. These are all the what is called limitations of the test. Got it? So in any case of rabies, you don't worry. These are the available tests for academic purpose. You call the microbiologist. We will come. We will take the sample and we will do all those things. Okay. So with this, I complete the basic virology of the virus. Okay. And next they will tell what is the pathogenesis, what is the clinical picture, how to prevent, prophylactic, anything. I will see you in the panel discussion. Thank you.
Thank you very much, Dr. Surya Kumar sir, for the wonderful and elaborate discussion. So one quick question before you go. So will the rabies virus mutate? This is one of the questions asked by the attendees.
Any RNA virus mutation is possible.
Mutation is possible.
Yes, but not as frequently as influenza virus or other viruses. But mutation possible, not as frequently as other viruses.
Okay, perfect.
Thank you.
Thank you very much, sir. Yeah, we will come to the questions during the panel. Okay. Friends, so as and when Dr.
I got one more question. Why specifically knuckle skin?
Yeah.
Because this virus, if you see the pathogenesis, this virus commonly shed in 3 areas. One is salivary glands, another one is knuckle skin, and another one is cornea. These 3 places. Because of the reason we are taking corneal scraping, saliva, and skin biopsy of the face or knuckle skin actually. That is the reason. Okay. Thank you.
Thank you very much, sir. Thank you. So I have posted the guidelines. The guidelines are the latest guidelines released by Ministry of Health 2022 has a detailed discussion about the laboratory aspects also. So kindly, if you are interested, you can go through. I have posted that in the chat box. Due to the want of time, thank you, Surya Kumar sir, for the better walk-up. And during our actual course, we will dig deep into a full session on rabies virology and laboratory investigations.
I'll close my camera. Thank you.
Yes, sir, please. And also you can stop sharing.
Yes,
Now we will quickly move to the next area called pathogenesis of rabies. Now I invite Dr. Raghunandanan sir to to discuss on it. Sir, Dr. Raghunandanan sir. Raghunandanan sir.
Just make a call, Mohan.
Yeah,
make
sure.
a call, but Raghunandanan sir is probably traveling. You
No,
can.
no. We just had a discussion. He will be here only because I have his slides to be discussed. Yeah.
Yeah, you can share the slides and then. Meanwhile, I'll also call him. You can share the slides.
So meanwhile, okay, sir is not unmuted. Can sir be unmuted, please, Dr. Raghunandanan sir? Yeah. Sir, make him co-host, please.
Yeah, Mohan, you can share his slides. I think you have his slides.
Sir Raghunandan sir, what is the name in which you have joined? Raghunandan, RAGU. Oh, now you can unmute, sir. Yeah, please. Try unmute. You can unmute now. You are a co-host, sir. You can unmute. Can you try one more time, sir?
Hello.
Sir.
Yes, sir. You are audible, sir. Raghunandan sir, you are audible.
No, his mic is muted. I'm trying to unmute his mic.
Unmute Raghunandan sir.
Host, can you unmute his mic, please?
Yeah. Dr. Surya, please unmute his mic.
Sir, I'm co-host.
Yeah, you can do it. Co-host
No,
can do it.
Co-host, we can't, sir, actually.
So IT wing. Dr. Vijay Kumar, can you please unmute Dr. Raghunathan, sir? IT wing person, please unmute Dr. Raghunathan, sir.
So Shuri sir, till the unmute is there is another question. When can the sample be sent?
Yeah, when can be the sample? As early as possible to the laboratory. When you suspect rabies, whether it is antemortem or postmortem, take the sample as early as possible and send it to the laboratory. Before that, you discuss with the laboratory whether laboratories having the facility or not, because many of the laboratories not having the facility to diagnose rabies because it's not a routine infection. And many times we used to send the sample to NIMANS, Bangalore for further confirmation, or NIV for further confirmation.
சரி நான் கூப்பிட்டு நான் சொல்லிடுறேன். Okay.
So
okay. One second. Yes, sir. You are audible, sir. Raghunathan, sir.
Yeah, am I audible now?
Yes, sir. You are
You're
audible.
audible now, sir. Surya sir,
Okay,
you have
okay.
completed the response.
yeah, I completed the response. Thank you.
Okay, perfect. Thank you, sir. Thank you for that. Raghunathan sir, so welcome back. Technical
sharing.
glitches are everywhere. I'm going to share the slides. Yes. Over to you, sir.
Am I audible, sir?
Perfect, sir.
Am I audible?
Yes, sir. Audible, sir. You're audible, sir.
You are audible.
Am I audible?
Yes, sir. You are audible, sir.
Yeah, thank you. So, good evening, all. It's my pleasure to give the talk today on pathogenesis of rabies. Before we go to the presentation, I thank the Indian Medical Association State Branch, in particular CGP, for organizing this, I would say, a mega event of CME on rabies, which is a starting of our infectious disease course for the next 6 months. After Dr. Surya Kumar's talk, I was a little bit concerned he's going to touch my topic also. Thank Dr. Surya Kumar for confining yourself to only the virus component. Next slide. I think all of us know it's an acute viral disease which causes fatal encephalitis in virtually all the warm-blooded animals, including man, and it is 100% fatal, but at the same time, it is 100% preventable. Okay, next slide. Again, something on history. This disease is known to humanity for more than, I would say, 2,000, 3,000 years, because it is even reported before Christ. But they say it is also Rabies, but means in Sanskrit to do violence. You will be seeing later in clinical features that some of the patients may be very violent, trying to escape from the ward, something like that. Next slide. Again, we have some evidence showing some pictures. Next slide. Showing the pictures of animal bite that is being occurring. Again, this is a very great slide. All of us know Dr. Louis Pasteur, the man behind the invention of this great vaccine. And you can see the first beneficiary sitting there in the chair, and Dr. Louis Pasteur is observing the vaccination from beginning. In fact, those days they used to make from the neural tissues of spinal cord, where we know we used to get a lot of adverse events following immunization in the form of demyelination. But today, thanks to technology, that we have got a beautiful, wonderful vaccines now. Incidentally, interesting information, Dr. Louis Pasteur is not a medical doctor. He is a plant microbiologist by profession. Since he saw so many people dying because of this dog bite, he changed his area of research to rabies vaccination. Next slide. Again, as previous speakers have told, mostly it is dogs, 95%, but still we should remember that cats come next. All our very domestic animals in our day-to-day practice, especially in rural practice, we do get cows, buffaloes, sheep, goats, all these things. In fact, wild animals means monkeys. We have to be nari, onai, all these also come into the picture. And so we have to be, in fact, any wild animal comes into category 3 straight away. So as far as we are concerned, 95% are dogs. As Dr. Surya Kumar rightly said, we should be aware of cats and other domestic animals also. Next. Can I have the next slide? We are talking about wild animals. Can I have the next slide?
Or please change the slide.
I have changed it.
No,
sir.
I think one slide before.
Yes. No,
Yeah.
it is okay.
So wild animals, as I already mentioned, jackals, monkeys, bears, some bats. Again, interesting thing about bats, we can have some discussion. In India, we do have some reports from northeastern states regarding bats, but especially in US, it is well reported also. Okay, next. Next slide, yeah. As far as rabid dogs are concerned, we can have 2 types of rabies. Next slide. Next slide. Next slide, please. Am I audible, sir?
Sir, you are audible. I have changed the slides. 2 types of rabies. Maybe.
Hello, am I audible?
You are audible, sir.
Yeah, so there can be 2 types of rabies in animals, especially we call it as furious rabies and the dumb rabies. The classical most common is the furious, where we know a rabid dog can bite as many as people possible. In fact, around 30-40 are being reported. So it bites even the owner of the dog, it can bite because of furiousness. We'll have some discussion later why it bites. But other form also known, that is the dumb rabies, where a pet dog can become very it cannot have food, drink, or it will not come. Slowly it go to silence and it can bite some objects at home. So that can be other extreme of animal rabies also. But most common what we see is furious form. Next. Next slide, please. Yeah. So we have already seen that it can be reported. In fact, when we interact with our veterinary doctors, colleagues, they have a lot of videos of animal rabies also. They also behave in a very funny and abnormal manner. So we should be aware, especially in rural practice, rabies in other cattle are well reported. Next. Yeah, again, we have to be very careful with cats. In fact, they say cat bite is more dangerous than dogs because cats have a very long, sharp canine tooth. So if a rabid cat bites, it's a deep intramuscular bite, and if it has a virus, it can inject very deep into the muscle tissue. So don't ignore cat bites or scratches. Next. Again, mode of transmission, we already know that it's mainly from bites, licks, or scratches, but rarely it has been reported as inhalations or even through organ transplantation. Some Scandinavian countries have reported. And we are eating a meat, Dr. Surya Kumar was mentioning. Is it a sexual? I leave the question to Dr. Surya Kumar. It has been a little bit controversial, but just I thought I'll just put it. It can be technically. Okay, next. Next. Yeah, of course, rat bite. We'll come to domestic rat. They say technically it cannot, but normally we advise for all rat bites. Yeah, as Dr. Surya Kumar said, it's a bullet-shaped virus, and we call it as a king of virus. I just explained the pathogenesis of this virus because it's a very, very smart virus. This virus, once it is injected into the skin or underlying tissue, it gets into the nerve fibrils. Through the muscle tissue, it multiplies, again it gets into the nerve fibrils, and it ascends through the spinal cord. Next slide. Next slide. Next slide, I'll come to this. Next slide. Yeah, so in this picture, you can see when the dog bites and the virus gets into the nerve fibrils, it ascends through the peripheral nerves, through the spinal cord, it reaches the brain. So it's such a smart virus. Once it enters the nerve fibrils, our immune system cannot detect this virus. It doesn't show its proteins and other things for our system to detect it. So the message is, if you want to get protection against rabies, only way and the best way is only to get vaccinated. In fact, we have protocol for pre-exposure vaccinations. Even before a dog bite, you can get. So many people will ask, sir, the doubt definitely, even if it's a doubt, please go ahead with vaccination, because even on dog, no bite also, you can go for vaccination. So this is a very, very smart virus, and it's also called king of virus. So from the moment it enters the skin and subcutaneous, muscle tissue, till it enters the circulation, we call it as incubation period. So roughly it is around maybe 2 to 3 weeks to maximum 6 months we have reported. Very rarely more than that. Again, this incubation period depends on the site of the bite also. As you can see in this picture, if the bite is close to the head and neck, the incubation period will be very quick compared to the bite in the leg. Dr. Morgan, go to the previous slides. Previous slide. Mohan Kumar.
Dr. Mohan Kumar. Can you please go to the previous slide? Dr. Mohan.
Change it, sir. My internet is a little bit unstable. Yeah. I've changed.
Yeah. I think this is a very interesting slide to know how really this virus behaves by various structures. They say it's a negative stranded RNA virus, and it has 5 important structural proteins. We call it as RNA dependent DNA polymerase. They call it as L, a nucleoprotein, that is N, a phosphorylated protein P, matrix protein M, and the external surface glycoprotein. So all this N, P, and L, they together called as RNA complex. They play a significant role. We call it as RNP. They play a significant role in establishment of immunological memory and long-lasting immunity. But the most important thing Dr. Surya Kumar also touched is the G protein, that is surface glycoprotein. It is an antigen capable of inducing the RV neutralizing antibodies, which are the major immune factors. So this G protein is practically very, very useful for us to produce the antibodies. Next. Next slide. Yeah. So what I already described, you can see here from the site of peripheral bite through the nerves, dorsal root ganglia, spinal cord, brain. It enters the brain and enters the circulation and salivary glands and other organs. So it gets excreted in the saliva. So especially when it comes through the dog, again it bites when the saliva is the route of transmission to other animals and human beings. So it is very, very neurotrophic. And there is no viremia. This is a very, very important point. As I said, since it ascends through the nerve tissue. Practically, we don't see a viremia. By the time it enters circulation, patient develops symptoms and usually he dies in a day or two. Okay, next. So how to get inactivated? Again, all of us know that immediately wound washing for 15 minutes with soap and water is important. Again, you can use some other detergents also. So luckily, it is easily gets deactivated by all these measures. Next. Again, you can see that because there was one question regarding milk, whether milk can be source of thing. Again, it clearly says it can be deactivated by boiling nicely or pasteurization. Incubation, again, I already mentioned. Next slide. Again, incubation I already mentioned, depends on the size. If it is head and neck, quickly it can spread. Severity. Again, from our practice, we have seen most of the dogs, they love to bite in the face, especially in children. They bite there and also multiple places. It bites not at one point. Sometimes a furious dog can multiple at multiple sites. Again, the amount of virus, already I mentioned, any wild animal is dangerous always. And protection by clothing also protects to some extent. X. So we'll go to some nuances of this virus, how this triggers the problem in our system. They talk about three important parameters. They call it as neuroinvasiveness, neurotropism, and neurovirulence. They are the major factors that determines. As I said, it is normally transmitted from the peripheral side through the axon terminals, and it goes in a retrograde direction. Again, Dr. Surya Kumar mentioned about two types of viruses. Actually, I should thank Surya Kumar. He gave a nice example. Circus singathiyum. So what street are rabies viruses that are present in the dogs, which can transmit in the community, and tissue cultured vaccines are what we use for our vaccine manufacturing. So street RV strains are very, very neuro-invasive. That is the point. Next. The major factors that determines the virulence of the rabies virus are virus uptake by the cells, cell-to-cell spread, and the rate of virus replication and the expression of the G protein. I already mentioned about that. And again, pathogenicity correlates directly with the kinetics of these things, but inversely with the rate of replication and expression level of rabies virus G protein. Next slide. Again, it is a multigenic trait. Pathogenicity, it's a multigenic trait involving different RV encoded proteins, which I already described. But G protein is a major determinant of pathogenesis, and it facilitates fast virus entry and fast transsynaptic spread. And together they cause other viral elements determining the pathogenicity. Next slide. Again, little bit of apoptosis. They say the pathogenicity of RV correlates inversely. That's important. Inversely with its capacity to induce neuronal apoptosis. There is a direct correlation between the RVG expression level and the extent of apoptosis. So if the virus is virulent, it doesn't induce apoptosis and silently it ascends up to the brain. That's what that street viruses are notorious to do that. Next slide. So this is another important point. That's a concept you should understand. Infection with non-pathogenic RV that is used for vaccines, they are much stronger activation of the pathway called nuclear factor pathway than infection with pathogenic RV. So that is an added advantage. since this non-pathogenic strongly activates this pathway, it triggers a robust of immune response that might serve to confine replication of this non-pathogenic to the primary site of infection, and by producing antibody, it can clear the infection. So this is how our non-pathogenic viruses are used for making the vaccinations. Next. So just to complete as postmortem diagnosis, sometimes we do postmortem diagnosis because sometimes we are not very sure whether the patient died due to rabies or some other encephalitis. So for which brain biopsy is useful. Again, this virus characteristically picks up brainstem, basal ganglia, spinal cord, or dorsal root ganglia. And all of us have read about Negri bodies. It is a pathognomonic finding. What is that? It is a cytoplasmic round eosinophilic inclusions found in hippocampus and cerebellum. But it is not found in every case of Negri bodies. If it is there, it is taken as positive. If it is negative, still you can't exclude rabies because they say around 40 to 50% only they can pick up these Negri bodies. So to conclude, next slide. So these are the carry-home message that I want to tell. The major factors that determine the virulence are the virus uptake, set-to-cell spread, rate of virus replication, and the expression of RV glycoprotein. We already said it spreads in the retrograde manner, and it is a multigenic trait involving different RV encoded proteins with transcriptional elements. Again, the G protein is a major determinant of pathogenesis. Infection with non-pathogenic RV causes stronger activation of that pathway that helps in development of immunity to our system. And we have to go for attenuated RV strains replicate very fast. So we have to go for attenuated RV strains to produce vaccines in future. Maybe I want to know from other speakers whether we have already have the vaccines of attenuated RV in the market. That I'm not sure about that. That can help a better immune response in to our patients. So the first aid for any dog bite is thorough wound washing, which goes a long way in our management. And not every dog that bites a person is rabid, but we may not know whether that particular dog had rabies or not. So that is why in public health domain, we assume every dog bite might be a rabid dog and start the post-exposure prophylaxis. We'll discuss something on pre-exposure also later in the discussion. Thanks for the opportunity. Over to Dr. Mohan Kumar.
So thank you, sir. Thank you, sir, for the wonderful discussion. It was like walk through to our college days where we learned about pathophysiology and pathogenesis of infections. And one thing is very clear. This rabies virus is actually king of virus, and it is very, very smart because it cannot be detected in the blood or anywhere, because once we detect it, it's already there everywhere because it directly transmits to the brain. And thanks for walking through, sir. And we will have more discussions when we are going to the discussion panel. Now I welcome Dr. Naminathan, sir, to talk about rabies and its vaccinations and management. Sir, over to Dr. Naminathan, sir.
Friends, once again, warm good evening to you from Infectious Disease Certificate Course Coordinators. Friends, I like to thank my friends, Dr. Mohan Kumar, a renowned epidemiologist, Dr. Kulandeswamy sir, Director of Public Health, retired, and Dr. Surya Kumar, a renowned microbiologist, and Dr. Raghunandan, general physician, par excellent physician from MMC Madras, and my friend Dr. Suresh Kumar, ID specialist from Apollo. Friends, now we are going to go to the next very important discussion, that is how to manage a person who comes to your clinic with an exposure. So first thing we must know, as per WHO classification, exposure to rabies is divided into three categories: category 1, category 2, and category 3. As already highlighted, it's mere touching or feeding the animals. or licking on an intact skin. If there is a doubt that there is a skin is not intact, it will automatically go to category 2. So here there is no prophylaxis that is required. Category 2 is the most important patients that they come to you. Category 2 is very, very important because nibbling of an uncovered skin, either with the teeth or with the paws, with the minor scratches or abrasions. The most important thing is without bleeding. It is not the depth or it's not the length. It is absence of bleeding. If there is a bleeding, it automatically becomes category 3. Even a minor nibbling with the bleeding becomes 3. If there is no bleeding, then it's category 2. So in category 2, as already highlighted, it's immediate anti-rabies vaccination, post-exposure prophylaxis, which I'm going to tell you later. Category 3 is very, very important because it is the one that we need to pay more attention, because here you have either single or multiple transdermal bites. How do you say transdermal bites? If it is transdermal bite, there'll be bleeding. Or it could be scratches also, that's transdermal. So either contamination of the mucous membrane with saliva from licks or on licks on a broken skin. Now WHO has added exposure to bats, though this may not be relevant to India because in India we don't have bat rabies. This is to other countries other than India. So some of the doctors who are attending this CME are from Dubai and other places. I see some of the doctors from US and also from Europe. There you need to give importance to the exposure to bats. So main thing is, if there is an exposure with bleeding, it automatically becomes category 3. Please do not look at how whether it is single or multiple, whether it is deep or shallow, whether it is a short bite or a lengthy bite. If there is a bleeding, automatically it's category 3. So this is a medical emergency as highlighted earlier. You need to immediately give rabies immunoglobulin or monoclonal antibodies at the bite site along with post-exposure vaccination. This is very simple. You have to be very, everybody who attends this meeting, you can take a picture of this one and then you can keep it on the table. So this is going to be very, very important because rabies, I'm sure, if you don't diagnose properly, if you don't treat properly, the fatality is very high and there is a medical legal possibility that you will be getting trapped. So you must know about this categorization and everybody should practice categorization. Coming to frequently asked questions, as already highlighted, only thing I want to tell is house rats, what we call is mungieli, small ones, they are not included in a rat bite. Whereas if it is a wild rat, street rat, if you are bitten by a rat in the hotel or in the railway station or anywhere in the streets, you need to vaccinate. That's very, very important. Perichally, you need to vaccinate. Apart from that, all warm-blooded animals you need to vaccinate. That's very, very important. One important thing is, suppose if you are bitten by a bird or a rabbit or a snake or an alligator or a tortoise, you need not vaccinate, because these were the questions that were asked by doctors from throughout the country to my phone. I get phone call regarding rabies every now and then. So very interesting questions they ask me. Recently, I heard one of the doctors from Andhra Pradesh call me that the alligator has bitten one person. Should we give rabies vaccine? So please remember, many times parents will come and tell you, doctor, en kulandhikku vandu kadikila, nails vechu nagatha vechu poonda na kannala paathen. So dog bite vaccine dana idu naai kadikila, poona kadikila nu solvanga. Please remember, these animals keep pawing, that is, they keep on licking their nails. The viral load in the nails is as heavy as that in the oral cavity. So even a scratch with a nail has to be considered as a category 2 bite, and then you need to give vaccine. If there is a bleed, you need to consider it as a category 3 bite. Whether it's biting or scratching with nails, both are same. And sometimes they tend to fight with you, telling that my dog has not gone to the street, it's always inside my house. We are on 3rd floor. My dog has not come to the ground floor right from puppy. No exposure to anything. My dog is a pet dog. My dog is a pedigree dog. My dog has been vaccinated thoroughly. I got a vaccination chart. My dog is a small puppy, now only a few days old. So please remember, if it is a dog, you need to vaccinate. So whatever the dog is, you need to vaccinate. Please remember, the vaccination in dogs is given to protect the dog against the animal rabies, to reduce the incidence of rabies in dogs. It does not have any protection for us. So even in a vaccinated dog, there is chances that the dog may not be protected. There are various factors that give vaccine efficacy to the dog. You cannot assure 100% vaccine protected dog just by vaccination alone. So you need to give vaccine even if it is bitten by a vaccinated dog. That's a very, very important, because many times we face this question. In post-exposure prophylaxis, the most important thing, as highlighted by Dr. Raghunandan sir, thorough cleaning with a running tap water with a soap. And the most important thing, WHO has updated. Previously it was 10 minutes, now it is 15 minutes. Most of the time they will come running to you the moment it is bitten. So you have to ask them to go to the toilet and buy a soap, wash it for 15 minutes. That's very, very important, because it is very, very important. It is said that it will reduce the viral load. That means its most important crux of the matter lies in washing with running tap water with soap for 15 minutes. That's very, very important. Second thing is, after washing, you need to apply some virucidal agents like providone iodine, or if you don't have providone iodine, possibly go home and apply this aftershave lotion. So that is very, very important. Some of the viruses that are not washed will be killed with your virucidal agents. Because please remember, rabies virus is very, very virus. So when you take this first step properly, you can eradicate, you can destroy all the viruses in the muscle fibers. And another important thing is, sometimes the parents will come running, it has bitten the face, the child will have an ugly face, or there is a bleeding. Kindly do suturing immediately. Never do suturing. If at all, if it is a life-threatening or there is a massive bleed, what you need to do is, you need to infiltrate locally after thorough washing with soap and water for 15 minutes. After applying virucidal agents, you need to infiltrate with rabies immunoglobulin or monoclonal antibodies. Then you need to take a suture, use minimal number of sutures, and have a loose suturing. Do not have a tight suturing, because that will help the virus to penetrate deep into the muscle fibers and enter into the neurons. So regarding suturing, as far as possible, try to avoid. So coming to the anti-rabies vaccine, you have pre-exposure prophylaxis particularly for veterinarians or dog catchers or corporation workers or postmortem or postmans, or for children who have pets at home, or for adults who have dogs or cats at home. You can give pre-exposure prophylaxis. There are two ways. One is intradermal, another is intramuscular. If you are not well versed with intradermal, you can give intramuscular. In intramuscular, if you have a purified chick embryo vaccine, it's 1 ml, and if it is a virocell vaccine, it is 0.5 ml. You have to give on days 0, 7, 28. Intradermal also 0.1 ml, 1 dose at 0, 7, and 28. So this is for before you being bitten by a dog or getting exposed to rabies virus. Commonly what we see in our practice is post-exposure. In intradermal, we need to give 0.1 ml, 2 doses at different sites on day 0, day 3, and day 7. This is the latest WHO recommendation. For IM, you need to give full vial of 1 dose each on day 3, 7, 3 days, and then on last one, 4th dose, either from 14th day to 28th day. Previously, we had 14th day and 28th day, 5 doses. Now the recommendation is 4 doses. The last one is from 14th day to 28th day. Another important thing which we see in our practice very commonly when we encounter in our practice is a child who has taken either pre-exposure vaccine or post-exposure vaccine adequately. They come to you being re-exposed. The child was bitten. Sir, last week, child was given a ARV, completed the course. Now within a week, child has got exposed. Cat has bitten or the dog has pawed. So in such a situation, after the last dose, within 3 months, if the child comes back to you, you need not vaccinate because this vaccine will be giving protection. If they come to you after 3 months, you can either give ID, intradermal or IM. The dose is, it has to be given on 2 doses, 0 and 3. Please remember, for a re-exposure in a child who has received full dose of pre-exposure vaccination or a post-exposure vaccination, full course, even in category 3, it's enough if you give 0 and 3 anti-rabies vaccine. No need for immunoglobulin. That's very, very important. So this point you have to stress them, particularly those who have pet animals. You can tell them that you can give pre-exposure vaccination prophylaxis so that they can save the money even if there is a re-exposure. Sometimes in practice, we see patients coming to us after 1 week after the bite, after 1 month after bite. So please remember, irrespective of the time lapse, if they come to you, treat them as per a fresh case, because the incubation period, as highlighted earlier, from 4 days to 6 years. Sometimes rarely it is even longer than that. So we don't know whether this child could be still in incubation period. So irrespective of the time delay, treat as per the category. If it is a category 2 exposure, give full course post-exposure anti-rabies vaccine. If it is category 3, even the wound is healed, give anti-rabies immunoglobulin or monoclonal antibodies, and then give a full course of vaccination. That's very, very important because this is a the lag period is long. Another question which the doctors ask me, particularly students ask me, is somebody gets a virus. For example, if somebody gets a flu virus infection, category B flu infection, we give antiviral drugs. We treat the child. If the child has got hepatitis infection, we treat the child for hepatitis. If the child has got a typhoid infection, we treat for typhoid. Whereas we say that the rabies virus has entered the body, and what is the purpose of giving a vaccine after the virus has entered the body? There's a common question, particularly when I take class for the undergraduate students or postgraduate students. Please, as I told you, this virus stays in the muscles, multiplies for a longer time. There is a lag period. We use this lag period by giving a vaccine and producing antibodies. So had there been no lag period, by this time the whole world would have died of rabies, because on an average, throughout globally, 60,000 animal bites and 20,000 dog bites in India. And on an average, every 1 hour, 2 persons die. Because by the time we started this meeting, 4 o'clock, now 2 persons in India would have died of rabies. That is what I'm telling is only tip of the iceberg. Many underreporting, so it'd be really more. Another important thing is, sometimes you ask the patient, or tell them about the 0, 3, 7, 14 to 28, ask them to come on 3rd day. They will come to you after 3 weeks. They will come to you after 3 months. Sometimes they will come to you after 3 years. Please remember, because of the presence of the memory cells, as by the day they come to you, take it as the day of schedule and then continue the schedule. For example, you ask them to come on 7th day, they come after 7 weeks. Please consider that 7 weeks day as 7th day and continue, then 14th day you have to give. To continue the schedule, no need to restart the schedule. That's very, very important in a lapse vaccination. And a common question, even one of the doctors have asked, should we restrict non-vegetarian? There is no diet restriction, please remember. If at all you want to restrict, only alcohol has to be restricted, because alcohol for any vaccine, it reduces the seroconversion, the particular vaccine. That's very, very important. And sometimes even a single drop of blood at the exposed site is category 3. Always we need to give rabies immunoglobulin or monoclonal antibodies along with post-exposure ARV, because they tell the chinna oru sottu ratham mattum vanchum doctor, the bite theriyala kannuke theriyala or chinna drop mattum dhaan irundhuchu. Even if there's a small drop, it is category 3. Please remember, it is not a lengthy bite or a deep bite. Sometimes, as I told you, for re-exposure, I already informed you, you have to give 0 and 3 alone, no need for, even in category 3, no need for RIG. Sometimes you have lots of questions. One of the pediatrician from Karur has asked, what is the management? Has there any reported recovery from survivors from the rabies? Actually, as per some of the literatures, there are 6 survivors, but conventional critical care from 1990, only 1 survivor as per literature. And a Milwaukee protocol that is called chemical induced coma. The survival rate is slightly high, but the neurological outcome is very, very poor. Please remember, neither rabies or monoclonal antibodies or rabies vaccine benefits a person once the symptoms have appeared and there is no antiviral effective therapy. Pre-exposure, as I already told you, 3 doses, it is given to high-risk persons. And very, very important, frequently asked questions in therapeutic doubts. Sometimes they would have started the vaccine in Kerala and they will come to Tamil Nadu for 2nd dose or 3rd dose. The particular brand available is not available in your hospital. What to do? What WHO says is definitely you try not to interchange the brands. But if it is not possible, if that particular brand you are not able to get it, you can change it. But as a routine, do not interchange the brands. And if the child has received intradermal vaccine, do not go to IM. Or the child has received IM vaccine, continue with IM, do not change to ID. That's very, very important. Another important question, what they ask is, can I store this immunoglobulin or monoclonal antibodies because they are costly? Can I store it in the fridge and then reuse for the next patient? Of course, you can store it. The vaccines are lyophilized powders. Once you reconstitute vaccine, you have to give it within 4 to 6 hours. Whereas immunoglobulins and monoclonal antibodies, you can be stored for the next, particularly immunoglobulin can be stored for the next patient, but it should be sterile precaution. And sometimes when you're giving ID, you must notice there is a wheel that is appearing at the ID site. If there is no wheel, that there is a technique failure. Probably it would have gone to subcutaneous plane. If in subcutaneous plane there is no dendritic cells, in intradermal plane only dendritic cells are there. So the vaccine seroprotection happens only in intradermal technique. If there is no wheel, you need to repeat ID technique by the site. Repeat it immediately by the same site, by the site. And should every patient who comes to you receive TT? That's very, very important. Most of the children are adequately immunized according to the age. In those children, TT need not be given. Sometimes adults we see, they don't have a history of TT injection. They'll tell that they have not taken, I don't have a record. In those patients, please give an injection of TT and tell them this single shot of TT is not going to protect you for future. Ideally, you need to give 3 doses of DT. 1 dose now and 1 dose 4 weeks later, another dose after 6 months. But if the patient is not to you, at least ask them to come after 1 month, particularly when they are coming for the 28th day of ARV, give another dose of TT so that they will give a longer protection. So no single dose of TT. And sometimes we see patients coming to you for repeatedly TT, small injection, small hand bite TT, thorn prick TT, like that. Never give TT like that. Tell them the single TT is not going to protect you. Give 1 TT and give 4 weeks later, then rest of next 5 years they will be protected. Suppose sometimes if you ask the nurse to give the vaccine, sometimes if the nurse gives in the gluteal region, it is an invalid vaccine. Please ignore that vaccine and give it in the proper appropriate site. For children below 7 years, you need to give anterolateral mid-thigh. That is the area of vastus lateralis where you don't have nerve or where you don't have a thick pad of fat or where you don't have lots of blood vessels. Anterolateral mid-thigh. That is the area you need to give for children below 7 years. For children above 7 years at the insertion of deltoid. Sometimes even after vaccination, we have seen deaths that's happening. Most of the time by postmortem findings and doing auditing, we have found out that most probably the virus must have gone directly into the nerve ending at the bite site, or a category 3 bite that was not given RAG because parents wouldn't have told about the bleeding. Immunoglobulin or monoclonal antibodies was not given. That's the main reason for the death following vaccination. Sometimes how to reduce this rabies load. India is called the capital of rabies. So how to reduce this? Now government has started a vaccine, mass oral rabies vaccine for street dogs. That is called National Action for the Prevention of Rabies. That's NAPRI. By 2030, they want to reduce the street dog rabies to 0 by keeping this some baits, some food with the oral vaccine. It will be kept in all streets. If nearly 85% of the street dogs eat this, they will be protected. So in areas where oral rabies vaccine have been initiated, they have become rabies free. For example, Goa is now a rabies free part in India. Apart from Lakshadweep and Andaman, they are islands. Sometimes we see rare condition in which village people will come that whole village and the maad paal kudicham doctor. Now the cow has died after 10 days. What to do? Please remember, rabies virus is not excreted in the milk. And luckily, all of us drink milk only after boiling for coffee or tea or Horlicks. So boiling kills the virus. So even in a rabid cow's milk consumption, no need to give anti-rabies vaccine. And if the patient is immunocompromised, for example, if the patient is taking steroids or a patient with HIV or immunocompromised patients, irrespective of the exposure, whether it is category 2 or category 3, you have to consider it as category 3 and give full post-exposure prophylaxis with immunoglobulins or monoclonal antibodies. Another important question is sometimes some of the patients, they will come and ask you, can I observe the dog for 10 days? At the end of 10th day, the dog is all right. Shall I not come to you for vaccination? Or if the dog shows sign, shall I start ARV? Please remember, this observation of dog is not, it should not be taken into count for vaccination. If there is a dog bite, you need to start the vaccination. You need to give day 0, you need to give day 3, and you need to give day 7. And if the dog is normal on day 10, you can convert this into post-exposure, pre-exposure prophylaxis by giving day 28. That will convert it as a pre-exposure prophylaxis. So now, never wait for the, never change the dog and wait for 10 days and give vaccine. So you need to vaccinate on immediate day of contact. So another important question is, should we start antibiotics for every bite? That's not required because nowadays we have lots of antibiotic resistance in our country because we should not misuse antibiotics. For a smaller bite, minor scratch, no need for antibiotics. If there is a severe bite, multiple bite, particularly in the hands and soles or in the face or in genitalia, or there is a tendon injury or a joint injury, or the penetration is deep up to the bone, or in an immunocompromised persons, you need to, and the antibiotic of choice, because the saliva of these animals are polymicrobial, the antibiotic of choice is amoxicillin at the dose of 50 mg per kg per day, given at 3 divided doses, that be reconstituted, kept in the fridge and then given. So because of the polymicrobial nature, but it is not routine for all exposures. And sometimes they come and say that my wife is in the first trimester of pregnancy. Can this vaccine affect the fetus or lactating mother or a newborn or an elderly 100 years old? Whatever the stage they are, you need to give vaccine because there is no contraindication for rabies. As I told you, if you don't vaccinate, it's a 100% fatal disease. So do not, there is no absolute contraindication. Only absolute contraindication is anaphylaxis. Even in anaphylaxis in our center, what we do is, because it's going to be life-saving for the vaccine, we keep everything, including adrenaline, hydrocortisone, oxygen, ambu bag, everything ready and give the vaccine. If at all there is an anaphylaxis, we give adrenaline, save the patient, and then continue vaccination. So because it's a life or death, there is no contraindication for this vaccine. So coming to rabies immunoglobulin, equine rabies immunoglobulin 40 IU per kg weight. Previously, we were telling you as much as possible at the bite site and then give little the IM site. That has been taken off. You need to give 100% at the bite site. Suppose bite site is large, what you can do is you can dilute with normal saline and infiltrate every site. There are 10 bites, you need to infiltrate at 10 sites. That's very, very important. Human rabies immunoglobulin is costly. The dose is 20 IU per kg weight. As per WHO, for equine rabies, there is no need for test dose. But for practical reasons, for medical legal purposes, ideally you can give test dose and then see for hypersensitivity reaction and then give the full dose. But when you're giving any immunoglobulin, always keep yourself prepared with all the drugs I have mentioned earlier. So coming to the monoclonal antibodies, this is a newer one. My friend Dr. Suresh Kumar will tell you about the monoclonal antibodies, and we'll also discuss with you regarding the newer developments and the frequently asked questions. So thank you very much. So we will be happy to answer all your questions. Myself, Dr. Raghunandan sir, Dr. Suri Kumar, Dr. Mohan Kumar, Dr. Kulande Swami sir, Dr. Suresh Kumar, all 6 of us of this fellowship certificate course coordinators will be happy to answer all your questions. Now I hand over the mic to Dr. Suresh Kumar, ID specialist from Apollo.
Sir, yeah. So just before Dr. Suresh, sir, I will share a one page, and then I will allow you to share. Just give, yeah. So dear friends, like there are a lot of questions about the dosage, either on like pre, post, and the re-exposures, and on category 1, 2, and 3. Dr. Neminathan sir has clearly summarized those things in his slides. But for us, as a ready reckoner, so this is the screen. This is the page 22 of the updated national guidance, which I have shared. I will share this again one more time. And you kindly take a print out and keep it in the consultation room, specifically this dosage. We have injections per visit and also number of visits. Sarah has clearly told the adult is delta in muscle, and for the infant group, anterolateral part of thigh. Okay, and the second page is immediately on page number 23. Okay, which clearly tells about what happens when it is category 1, 2, or 3. It is whether it is immunized or non-immunized. So it has a clear walking through. Okay. So kindly take these 2 pages print out and keep it in your vicinity, and you can definitely refer as and when we handle a rabies case. It will be helpful for us. It is sir has just talked about all these areas, and definitely it will be useful. Okay. Thank you. And Dr. Surya Kumar.
For the sake of audience, rabies we are going to deal with even more detailed manner during our infectious disease certificate course. So because those doctors, around 650 doctors are attending, by joining this infectious disease course, you will be highly made, your knowledge will be shared to you so that you can tackle all the infections that you encounter in your day-to-day practice. I request all of you to consider joining this course. You can get the details about this course from Dr. Mohan Kumar. Mohan Kumar, you can share your number at the end so that you can contact him. He is one of the co-coordinators of this certificate course. I request all the friends attending this meeting consider joining this infectious disease certificate course, which is really useful because 90% of your practice is infections. Thank you. Over to Dr. Suresh Kumar.
Thank you, sir. Thanks for I sincerely thank the IMA CGP chapter for giving this wonderful opportunity, as well as my co-speakers. Already they did the job. So I'm going to do a couple of frequently asked questions. I thought of doing some update. I'll come back why I did the FAQs instead of an update. I'll come back in a minute and explain to you that. Before that, this is my disclosures. I'm an ID doctor. If you want, you can scan this QR code so that you know a little bit more about the stuff IDs and my teaching programs. And I don't bite. So please take your seat. So those who want to join a practice there, just sit for 15 minutes, learn and go to your practice so that you can learn a little bit more. Straight away I put, because a lot of theory has been spoken, I just show a couple of cases here. This is lady, she visited Marina Beach. During the Marina Beach visit, Usually in Marina Beach, people are taking some horse for people to for a ride. One of the small boy taking a horse and the horse came and bite this lady. So she came straight away to our ER. She's a 26-year-old female while walking in a beach bitten by a horse. So can this patient needs ARV? This is a post-test question because my previous speakers has alluded about this one. So how many say this patient needs ARV? I'll come back to this category of wound bit later part of it. How many says this patient needs? Put it in the chat box. So those who want to get a TNMSC credit points, please answer in the chat so that we can decide your adherence based upon your presence, your interactions with this chat box, so that we can have interactions towards the end also there. So how many patients sees, how many participants says this patient needs ARV? Because this is bitten by a horse. Okay, fine. I'll give a minute and move to the next slide there. Sure. So why this CME arranged? Because everybody knows Dr. Neminathan and so many other people also told nowadays, particularly half late, we are seeing a lot of rabies. Yeah, in fact, I need to thank Dr. Mohan because he only suggested this talk because this is a hot of topic right now. If you read the newspapers, if you see the news channels, almost every day the discussion is going on. For example, Kerala, couple of children, they got bitten by a dog. Vaccination is completed, but still they are dying. Why? The reason is keep on going, and social media people are keep on discussing, and every day people keep on calling us, oh, the dog bite happened, this bite happened, what to do there? So people keep on asking. So this is one of the common problem. Why this is a common problem? Because we are the leaders. Compared to any other country, the number of rabies deaths happening in India is more compared to any other country. And third thing, if you see the states except Goa, what is said, except Goa, most of the cases, suspected rabies cases has been reporting now. And third thing, if you see the news media, yes, rabies is there everywhere. And people are keep on talking about it. A lot of animal activities also talking about, and a lot of animal feeding is also going around, a lot of talks is around. And second thing, why I skip the advancements, the protocol called Milwaukee Protocol, keep the person on general anesthesia. This is a protocol followed from 2004 for rabies. There is no specific treatment. In fact, in your examinations, if your examiner asks the last question, what is the prognosis of rabies? That means that is a prognosis of you in the examination. That's the clue people give. Good examiners give a clue. They are not going to pass in these examinations. If you ask the questions, what is the prognosis of rabies? The Milwaukee Protocol was implemented in 2004. But from 2004 onwards, people put on Milwaukee Protocol. Hardly count only few people. As he rightly pointed out, 6 or 7 survivors only is there for the rabies. Most of the people has got rabies, they are not making it. So the Milwaukee Protocol is not working. What is going on? Lot of companies are working on the new drugs. One of the cancer drug they are reintroducing now. This is called HHC there. That's called homoharentonine. This is one of the cancer drugs. They find out this is killing the rabies virus in the lab, but not in the life. So it needs a lot of studies there. This is just coming up. So this theory is not going to help you in practice. This theory is not going to help you in practice. For example, Favipiravir also. Favipiravir, yes, people know during COVID time it tried. But again, this is all in theory. This is not in practice. So as far as rabies is concerned, only supportive care, post-exposure vaccinations, as well as we need to provide some amount of comfort to the patients who are dying. This is what we are doing right now. There is no major advancements. That's why I skip the advancements and put the FAQ, because you are all practicing clinicians. You need to know when I say a case, what I need to do. So I put it back. So this is why I put FAQs. And this is one of the algorithm books we released recently. In this algorithm, we written briefly. When a patient comes with an animal bite, we need to know, does this patient need post-exposure prophylaxis? And we need to identify some red flag signs. We do some focus history and examinations, taking care of the wound, rabies vaccinations, immunoglobulin, antibiotic prophylaxis, tetanus, and re-exposure. We need to do about it. So these things is required. This is one of the acronym previously used. This is one of the mnemonic people are using for rabies or animal bite. Take a proper history, do examinations. It's called helicopter approach. Liberally cleans the wound, irrigate the wound, closure. Think about it. And operative cleaning and closures, prophylactic antibiotics, and tetanus as well as rabies vaccinations. This is a simple mnemonic, but usually it's not going to help. I'll make it even more simple towards the end of my presentations. And this is the questions people keep on asking. What are all the animals I need to worry about it? Usually mammals you need to worry about it. Rodents you need not worry about it. For example, rat, squirrel. In bats, particularly birds, particularly bat in India, there is no cases. For example, bat in India transmit Nipah, but bat in India is not transmitting rabies. But if you see US, they say a bat find in the room itself, they're going to give the vaccinations. This is a difference. But why Indian bats are not transmitting, the answer is not known. but so far there is no reservoir for the rat, squirrel, even human. People call human bites also not going to transmit most of the time. I'll come back. Couple of exceptions are there. I'll show in the last couple of slides there. So we need to know what are all the animals going to transmit the rabies. Mammals always think about it, whether dog or cat, that's leader, but other animals also. But what are the things is not going to cause? Rat, squirrel, humans as well as bats in India. And this is one of the common questions people are asking. I was bitten by a puppy, particularly the puppy not even bitten me, just scratched me. My scratch, they put it as mark here. This is a scratch mark. So this is a puppy only there. Can I need to take the vaccination? This is a scratch. This is not a bite. I think Dr. Neminathan answered this one. Usually the animals, they do a lot of they lick the nails or lick usually they start licking the things. So it's very difficult to say whether bite or scratch by the history alone. Very difficult. Sometimes bite and scratch can happen together. And most of the animals, the habit, particularly when the animal has got rabies, it start licking everywhere and start licking the own nails. So with the nails also going to transmit. That's why the WHO guidelines clearly says category 2 bite. That means scratch will be there without any bleeding, or bite mark will be there without bleeding. We need to give the vaccinations. Why? Rabid dogs or rabid animal, usually they start licking most of the things. They start licking their own nails also. That's why the reason they are giving the thing. Second thing, puppy. Just usually first 3 months, if the mother is protected, for example, the mother dog is protected with the vaccinations regularly, it can transmit the immunity, but the immunity to the mother itself is doubtful. So don't think puppy is safe. This is not an exception to rule out ARV. So usually whether puppy or kitten, we need to give the vaccinations, keep in line, bottom line. So this is a WHO guidelines come in 2024. Reason 1, we need to ask whether the skin is intact. When the skin is intact, but the skin is broken, but there is no bleeding. This is called category 2. Skin is intact means category 1. Skin is broken means it's category 2. Skin is broken and bleeding or bite mark is that's category 3. All wild animals is category 3. For category 1, that's what Dr. Purandeswamy was keep on telling. There is no category 1 because some amount of lick, some amount of scratch, some amount of bite can happen. Usually always take close look at it. That's most important thing. There is no category 1 essentially, but category 2 or category 3. Category 1, most of the time, they won't come unless the animal died of rabies. Unless the animal died of rabies, that point of time, essentially, we consider as category 2 and give the persons with PEP. So this is a protocol we need to follow. So I'll show a couple of pictures. What is category 1? Category 1 means this is category 1. There is no major change in the skin, except we need to closely follow, or we can use some magnifying glasses to see. This is category 3. There is no need to worry about it. I'll come back to the suturing part bit later. I'll come back this. This is category 2 I've shown now. Scratch mark will be there, but there is no bleeding from the side. And this is again category 3 because we see the bite mark. A lot of things is there, even though there is no bleeding, but this is a bite mark is classically present, and this is not a standard dog or cat. Treating a dog and cat and other animal is quite different. I'll come back and explain what is the difference also. This is one of the bullock has bitten her there. So this is category 3 straight away. For this wound, I need to think about suturing. I'll come back and explain suturing part bit late. And this is one of the FAQs asked to me there. I got a pet cat. The cat is vaccinated. While playing and I provoked the cat. During the provocations, the cat bitten me there. Thus she needs PEP. Because people always say provoked bite is not required, unprovoked bite only think of rabies. So how many participants says this is a provoked bite, this is a vaccinated pet, I don't want to vaccinate this person. How many says no? Vaccinated, provoked. Please put in a chat so that we can discuss it again. Yes, this is cat, not like a dog. And second thing, this is category 3. I don't want to miss it. Till 10 days observation. That's also touched upon by Dr. Neminathan. I'll come back the 10 days rule also. Check cat antibody titers. There is no studies available right now. So what are we going to do now? So this is the choices. Please go ahead and vote so that we can discuss. And this is a beautiful chart given by the WHO. What is provoked and what is unprovoked? This is very, very, very difficult for us to say what is provoked and what is unprovoked. So if you read the guidelines, this is not going to help you. Provoked bite or unprovoked bite is not a reason whether the animal is provoked or unprovoked. If it is required category 1, category 2, category 3, if the animal is a mammal, it's not a rodent, we need to think about the vaccinations. So don't go by the history of provoked bite or unprovoked bite. That has got no value. Then people keep on asking, my pet is vaccinated. I regularly vaccinate. During the time of COVID, you know, all of us are vaccinated. And most of us developed COVID after the vaccinations. The vaccination is not 100% effective one. And a lot of other issues also, cold chain, everything, and revaccinations. Animals should be revaccinated every year. Not one shot of vaccination is going to maintain the titer. So the vaccination history is also unreliable. Indian dogs or Indian animals are unpredictable. And second thing, vaccines are not always going to give 100% protections to you. So vaccinated pet, vaccinated dog is not going to be the answer. This is what WHO guidelines clearly says. So provoked by. Second thing, the 10-day rule. Yes, if you read the guidelines, most of the guidelines, whether the animal is traceable, whether the animal is a pet animal or stray animal. Pet means I can follow the animal. Most of the rabid dogs are rabid animal, particularly rabid dog and cat, they die within 7 days. After start manifesting only, they're going to bite you. Once they bite you, they will die within 7 days. That's why we need to monitor dog and cat. For other animals, people say 14 days you can able to track, but there is no good data. For dog and cat, there is a good data. If the animal is traceable, you can follow the animal for 7 to 10 days, but don't wait. You take the vaccinations, post-exposure vaccinations, but follow the animal. If the animal is alive, there is no need for further vaccinations and further need for immunoglobulin, because immunoglobulin you can give up to 7 days of the bite. And after the first dose of injections, you can wait for 7 days. So no need to worry about immunoglobulin. If the animal is traceable, particularly the animal is dog or cat, you can observe the dog or cat for 7 days, maximum 10 days. For other animals, people say 14 days, but there is no good data. So this is an Indian data guidelines, what I'm talking about it. Indian dogs are unpredictable, Indian animals are unpredictable to me. And second thing, vaccines is not going to give 100% protections. Keep in mind, that's most important. And this is also Sarah's answer to you, because cow is bitten, common questions, whether the milk is going to transmit the disease, I boiled. But these are all the different categories. For example, the person who handled the milk, the person who milked the milk, whether he needs prophylaxis or not. The person is an unpasteurized milk. Some of the children, they take immediately the milk once it is ready. They want to consume it. And third thing is immunocompromised host. Who are going to do? So this is the data we usually say. Usually transmitted by saliva or neural tissues, or even organ transplants also possible. But milk and everything is not going to transmit, and most of the time we boil the milk. As rightly pointed by Dr. Surya, it is killed very easily with the heat. Second thing, gastric acid also is going to kill. So there is no worry if you have boiled that. If you've taken the boiled milk, there is no worry. But people who handle the thing, if they got cuts and cracks, you need, probably yes. People who are eating meat also, they're asking about it. Usually again, meat, they are cooking it, they are boiling it, they are going through the gastric acid is going to kill about it. But people who are cutting the meat, they need to be handled careful, particularly if they got cuts and cracks during the handling it, they're supposed to take. So these are case by case decisions only, not universal rule. But if the milk is boiled, there is no need to worry about it. And coming back to the suturing part, people keep on asking, can I suture? But this is a phase. In fact, this child was bitten by a stray dog. Pulled the child for almost a meter, and it was taken to the government hospital. Immediately they sutured and referred us. So this is what, but because of the ugly pictures, the CM was involved at the point of time, they referred to her hospital. So whether suturing can be done or not, suturing can be done provided if it is in the face, if it is the bleeding, if it is in the face, if it is in the bleeding, we need to suture it. Because, but what we need to do, we need to give immunoglobulin at the site of suturing. We need to do the loose sutures, not a tight sutures. Give wash adequately, give vaccines, give immunoglobulin at the site. Then you can do suturing, but do loose suturing, not a tight suturing. Otherwise, cosmetically, the child is not going to make it in the future. This is an young female child. We need to give these considerations. And again, this is a bleeding one, profuse bleeding. We can't stop the bleeding without suturing. So we need to do suture, give immunoglobulin, give suturing. That's also most important thing. WHO says usually no. That's what Dr. Neminana was talking about it. Usually no, but if bleeding, deep, cosmetic reasons, yes. But precautions, rig, loose sutures, not tight sutures. Then people keep on asking intradermal and intramuscular. Government sector is promoting intradermal. Why intradermal? This is amount of vaccine is very small, 0.1 ml. And second thing, 0.1 ml needed. So it saves a lot of vaccinations. For example, US has got a face huge problem. They got a vaccinations difficulty. So intradermal, they are giving it one. You are saving a lot of vaccines. But the efficacy is same. Yes, studies are compared. The efficacy data is existing right now. There is no major differences between intradermal and intramuscular. But what is more important, technique is good. People are talking about the Kerala death, intradermal tried or not. Because intradermal, suppose if you are giving subcutaneous, the absorption is not going to happen. So know the technique, the person should have experience, then you can give intradermal. Otherwise, intramuscular. Why GPs are preferring intramuscular? Because they lack the experiences of intradermal. So intramuscular and intradermal are equal. And people asking whether I can change intradermal to intramuscular. They have taken the first shot in the government hospital. Intradermal is given. Coming back to me, I am not experienced with intradermal. Can I give? Yes, guidelines says you can change. Similarly, the vaccines also. For example, I have given human diploid cell vaccine, but right now it's not available. For me, this is pure virocell rabies vaccine is available. Purified virocell is available to me. Can I take interchange? Yes, you can interchange. That's no problem. Usually try to stick to the same route, same vaccine, but if unavoidable, you can change it. That's what people are telling about it. We can change. Then people are asking about monoclonal antibodies. Why immunoglobulin? Immunoglobulin, for example, 2 immunoglobulin, equine immunoglobulin and half human immunoglobulin. Human immunoglobulin is very costly. That's why in government sector, they're giving equine immunoglobulin. Equine immunoglobulin is very cheap, but allergic reactions can happen. Efficacy wise is good, but availability is a challenge. Allergic reactions, anaphylaxis is a challenge. That is why this monoclonal antibodies has come into the market. Monoclonal antibodies are good, but unfortunately costly. Compared to the human immunoglobulin, monoclonal antibody is cheap. But compared to the equine immunoglobulin, monoclonal antibodies are costly. But efficacy wise are same. So if the person is affordable, if you don't want to have any anaphylactic reactions, monoclonal antibody. There are 2 types of monoclonal antibody. One Dr. Sar has shown, Rabies shield, that is called monoclonal. Now the 2 monoclonal antibodies are combining. A lot of monoclonal antibodies is coming up now. Then people are asking immunosuppress, what is the difference? Immunosuppress needs 5 doses. Whether 4 doses or 5 doses, other controversy. US, because of the vaccine shortage, they did the study. 4 doses of intramuscular is equal to 5 doses of intramuscular. 0, 3, 7, and 28. That is an ideal. Suppose immunocompromised host, don't cut short the 4th dose, give 5 doses. And similarly, intradermal, don't rely on it, give intramuscular. So in immunocompromised doses, we need to check the antibody titers also, whether the person produced antibody or not. That we need to do. And people keep on asking when to revaccinate. Usually, if you completed 1 courses of vaccination, that means 4 or 5 intramuscular or intradermal, new vaccines, not the old vaccines that used in the neural vaccines given in the umbilicus. Don't consider that one as a vaccine. Intradermal or intramuscular, new vaccines, the person completed once, it is effective most of the time 1 to 2 years. But if the bite happened after 3 months, 2 doses is needed. That's what Sir is clearly telling, 0 and 3 days. That's a booster we need to give it to improve our immunity. So the people keep on asking whether I need to give a booster or I need to take a 5 doses. There is no need for 5 doses or 4 doses. Once you completed a primary time, second time only 2 doses booster, but 2 after 3 months. Suppose the bite happened after 3 months, you are completing 1 schedule, give 2 doses only. That's more important. And this is a last case, sir. This is one of the case. I don't want to put the video here because I can't hide his face. So this man admitted with a severe abdominal pain, very restless. So we intubated initially, we don't have any clue. After intubations only, the person started behaving abnormally. He shows hydrophobia and aerophobia in intubations. By the time intubation, a lot of secretions was there. And a lot of secretion is pouring from the mouth also. The anesthetist intubated, he find a lot of secretions. In fact, some splash happened to him. And nurses putting a suctioning, they got some splashes. And similarly, during the course, he bitten also. Before intubations, he behaved very restless. He bitten one of the staff nurse. So what are you going to give? Post-exposure occupational prophylaxis. Some of the rabies cases, because we handle rabies cases also, PEP to all. And my housekeeping came and told a lot of secretions were there during the time of intubations. I only went and cleaned, but I didn't wear any PEP. PPE, I didn't wear any personal protective equipment. I'm not wearing. So this is one of the challenging questions people ask, but we usually do risk assessment. Bitten by a rabid person, usually human bites won't transmit rabies. But already the person is proven rabies. If he bites somebody, definitely it's category 3, I need to give you vaccinations. Similarly, a lot of secretions happening, the person intubating, splashing, he is not wearing any goggles. There is no PPE. Appropriate PPE is not wear. Risk of getting rabies is there theoretically, so give the vaccinations. But people cleaning the surface, environmental things, they are putting some agents, so there's no need to worry about it. So always do the risk assessment for post-exposure prophylaxis for people handling the rabies cases. This is very vital for people working in ICU setting. That's most important. Then people are asking about the prevention. One of the oral vaccines for the animals available in the Europe. This is for the wild animal, not for the domestic animal. It's very difficult to give for a domestic animal because this is a live vaccine. Sometimes the animals consume and get the rabies also. There is a big problem. So we are not recommending oral vaccines. One of the questions asked by one of the participants from Calcutta at that point of time. And people are asking why rabies vaccines not included in universal immunization program. This is one of the big challenge. We know we got a lot of stray animals, a lot of bites happening, a lot of death happening. but they did the cost-effective analysis saying that this is easily available vaccines, post-exposure is preventable, everything. But ideally, for example, US traveler coming to India, they take the vaccines because almost all Indian speeches contain the stay dog. All temples contain monkey. So we need to give the vaccination. That is why US traveler coming to India, Pakistan, this type of country, they need to take the vaccinations. If you read the thing, veterinarians are taking the vaccinations. When the country is endemic, for example, India is endemic to rabies. So this is a right time we need to give an universal preparation because only 2 or 3 doses only, 0, 7 and 21. This is a 2-3 doses is needed. If we give it, there is no need to worry about immunoglobulin, only booster is required. So this is one of the valid questions, but I think epidemiologists and public health specialists like Dr. Kurande Swami and Dr. Mohan can address better than we can. So I think my signal is lost. So we need to file the guidelines, and this is the rabies management protocol. Am I audible now? Am I audible?
You are.
Okay, thank you, sir. So this is a rabies management protocol given by WHO. We need to know the category, or we need to know the animal. Based upon the animal, based upon the category, they clearly mention about 10 days. Whether you can able to get the animal and follow the animal for 10 days, yes. I simplified things. This is the simplified versions. What sort of animal, whether wild or whether domestic, whether it's mammal or rodent, what category of wound we need to do. Category 1, just wash the wound. Category 2, wash plus vaccinations. Category 3, wash, vaccinations plus immunoglobulin. This is a management. But the helicopter is difficult, what is easy? When you encounter an animal bite, whether the wound needs care, all bites needs care, wash the wound. Whether simple running tap water is more than sufficient. If you got soap, that's fine, but there's no need to search for soap, just wash the wound. Antibiotic, usually cat bite, because cats has got sharp teeth, the depth is very difficult to assess. When the wound in the vascular area, face, genitals, we need to give the antibiotics. What antibiotic is shown below? Rabies vaccinations for all domestic as well as all mammals, yes. But for human, rat, it's not required. Squirrel is not required. TT for everybody, but depends upon the revaccination schedule. And other animals, other organisms like for dog, capnocytophagia. Cat means Pasteurella. Monkey means herpes B. I need to give acyclovir also. Human bite, hepatitis B risk is there. HIV risk is not there. Rabies risk is not there unless the person is rabid. So this is a short form we used to give. Keep the slides. And those who want to learn more, scan this QR code, fill the Google form and send request to the WhatsApp. You can join the group. They are coming with newsletters, coming with the podcast, coming with a lot of things, second opinions. All is coming up with the list of IDs. And this is a book we created, ID algorithm, what I'm discussing in this case. Those interested, just message us so that I can send the hard copy, or how to buy the hard copy also will let you know there. And thanks for the wonderful opportunity. I'll take a couple of questions at the end. Thank you.
Thank you, Dr.
Yeah, thank you,
Suresh,
sir.
for the excellent presentation. Mohan, are you there? Mohan, already time
Yes,
is
sir.
over. We said 4 to 6 p.m. Dr. Sendil and Dr. Anand. Now it is
Yes, sir.
already 6:20. So shall we take some questions?
Yes, sir. Please, sir. You can take some questions.
Yes, Mohan, if there are some questions, you can direct to us. Dr. Suri Kumar is there. Dr. Suresh Kumar is there. Dr. Raghunandan sir is there. Dr. Kurande Swami sir. All are there. Friends, all the speakers of today's Rabies CME are the faculty directors of infectious disease certificate course. I'm sure by the way we deliver this lecture, you will be confident that by joining this course, you can have an excellent knowledge on various infectious diseases. I request doctors who are already 600 doctors are there from 4 to 6 p.m. So I request all of you to consider joining this infectious disease certificate course. As soon as the conference is over, you can contact Dr. Mohan Kumar, who is an epidemiologist. He is a co-coordinator. I'll mention my number, his number. I also posted his number in the chat box. Please note down his number. I request everybody to note down his number. 97908 78976. Dr. Mohan Kumar, infectious disease certificate course of IMA CGP. Once again, I'll repeat the number. Please note it down or note it down in your phone or in the paper. Dr. Mohan Kumar, 97908 78976. 97908 78976. Yeah, you can go to the questions.
A quick fire, sir. Couple of cases there. 1 year child bitten by a dog, whether need vaccination?
Number one. Scroll up.
I'll answer a couple of things, sir. People are asking 5 years over whether vaccination needed just 2 doses.
Yeah. You need to give, you have to, irrespective of the time lapse from the bite and the visiting, because as I told you, incubation is very long. So you have to consider whatever the category, the patient says come to you after 5 years and says there was no bleeding, but the wound has healed. There is a little scar. If it is category 2, give post-exposure vaccination. Or if you think it is category 3, even if the wound is healed, you have to give at the bite site. So you have to consider, because of the long incubation period and the potential fatality associated, the day of contact has to be taken as day 0 and then vaccinated.
No
Other
denial.
question they asked about 5 years after any schedule. Yes, even 5 years or 10 years, only the 2 doses of booster is required when the bite happens, not regularly. But veterinary doctors regularly take the vaccinations every 2 years. But usually for us, if you have taken one primary schedule, either 4 doses or 5 doses of intradermal or intramuscular, some bite happened. First 3 months, there is no need for revaccinations. After 3 months, take 2 doses, 0 and 3 days. That's what required.
Scientifically speaks, after vaccination, we should go for titer of antibodies. If the titer of antibodies are up to the mark, no need to go for vaccine, but it is not available in India, that facility everywhere. So benefit of the doubt, we'll go for 0-3 doses if it is after 3 months.
Something
Dr. Rita Mani is doing
for practical reasons. Theoretically, you are right. For practical reasons, always it is better to give 0 and 3 in a in a person who has received adequate dose of pre-exposure, post-exposure. Sometimes they would have not taken adequate dose of post-exposure, and you cannot, in those cases, you cannot give 0 and 3. Say they would have taken 0, 3, 7, and they have not taken the full course. In those patients, you need to give, you cannot give 0, 3. You have to make sure that there is a documented evidence that they have taken pre-exposure or post-exposure. Document should be that. There is no document, you need to consider as a fresh case and then give full post-exposure.
Regarding the other questions, regarding the dose, they are asking about the equine. Equine is 40 international units per kilogram of the body weight. Each vial comes with 1,500 units. Human immunoglobulin, it's 20 international units per kilogram of the body weight. Each vial comes with either 150 or 300 units. The monoclonal antibody is called Rabies shield. The name is protected by Dr. Raminathan sir. This is 3.3 international units. But remember, the immunoglobulin, as much as possible, inject at the site. And remaining doses, for example, the wound is very small. You can't inject all the things at the site. Give it at a different site. For example, you are giving vaccines in one hand, you can give the immunoglobulin. One more important thing, never give vaccinations in gluteal region, because most of the GP that did a wrong mistakes, we do gluteal region. If gluteal region is given, we don't consider this a dose at all, because adipose tissue is more, it won't allow the absorption there. So gluteal region is not considered to be vaccinations. All vaccinations in deltoid, that's a vaccine. Pediatric settings, anterior lateral part of the that is everything there.
Yeah, if you are having a monoclonal antibody or immunoglobulin excess, please give it. If you are if around the bite site, if it is excess is there, still give it around the next nearby the bite site. So along the bite site or nearby place. That's the recommendation, latest recommendation.
Sir, I think we can wrap up because of the time.
Yeah.
And we can answer more questions during our additional discussions and other sessions. If you can wrap up and then hand over to
There's
IMA.
a WhatsApp group for interested doctors joining infectious disease. You can join that group. You can contact Dr. Mohan Kumar. So enrollment is already started. The first day of commencement of the course is on June 1st. It's an online on alternate Sundays. So it will not affect your practice. So more than 200 doctors have passed out. So I request everybody, lots of microbiologists, many pathologists, many pediatricians, general practitioners, physicians, many of them are there. I request everybody to join this course. This is a course which will be useful for all doctors.
So one last question, that pre-exposure they're asking about, veterinary doctors are taking, that's protecting the veterinary doctors. That is why I put one slide on universal precautions or universal introductions or vaccinations. Now pediatric societies, because children are vulnerable, they play with animals, they are recommending the children, all of us, for example, early morning people going for jogging, people are working late night, coming in a two-wheeler, almost all Indian streets contain dogs, better to take the vaccinations, that is effective. No need for immunoglobulin.
Yeah, you told about going for walking. if you look at the incidence of the ratio of dog to human in our country, in the daytime, for every 25 human beings, there is one dog. In the early morning and the night time, for every one person, there are 25 street dogs. Totally changes. So that is very, very interesting. So the ratio of human to dog changes. Yeah. Thank you, Sendil. Thank you, Anand.
Thank you, sir.
Thank you.
Thank you all.
Thank you, sir.
Thanks for taking
Really, it is a pleasure to have all our star speakers. And this is a record like almost close to 600, almost 80% of attendance is there till the end. So this itself shows the quality of the program, sir. I request all our members to enroll in the course. If it will be very much useful for your general practice and day-to-day practice. And I thank all the speakers and all the attendees. Thank you very much. Thank you, sir. Yes, sir.
Thank you, Sandil.
Thank
you,
sir.
Thank you,
sir.
speakers. Dr. Suryakumar, Dr.
Thank you all.
Mohammed,
Thank you all.
Dr. Suresh Kumar, Dr. Adandan sir, Dr. Prandevaswamy sir. Excellent speech. Thank you. Thank you, everyone. Thank all the audience for joining us for 2 hours. Thank you.